remember doing like one of the lightning checks at another SAEM, and like also being like, this room is crazy. There's 10 people in it, and I'm like,
okay.
looks like that person might be coming in.
Yeah, they seem to be like lingering and like turning the corner.
Oh, maybe not, because it's also the poster board for like SAEM is like right outside too.
It's also a good spot for us, although it's 8 in the morning.
Oh no, it's 8 a.m.
Yeah.
It's the.
I mean, I think regardless, spend some time putting something together.
Yeah.
Now we have ready.
Yeah, now we have something ready. Should we get started? It's like
We should probably start.
All right, y'all, we'll get started. Thank you for crawling out of bed this morning, getting your coffees, and coming to join us to talk about challenging conversations when time is always tight in the emergency department. And we're going to be talking about 3 communication frameworks that can help us out. My name's Gretchen Fuller. I am an emergency medicine physician and pediatric emergency medicine physician here at UT Austin. And outside of my clinical work, I also do mostly communication skills training in healthcare. So I'm the Assistant Director of Patient Experience at USACS, and I'm a faculty member of an organization called the Academy of Communication in Healthcare.
Good morning. Thanks for joining after Superstition, like we said. My name is Greg Wallingford. I'm emergency medicine trained, now palliative care doc. So some of these skills, and really like the alternate title here, I think could be simple tools I wish I had when I was in the emergency department. So what we're going to be going through today are just some really quick hits on frameworks that you can use when you feel like you're walking into a more difficult conversation or one turns difficult.
So think back to the last shift that you worked where emotions were running high, perhaps your own, or the patient or a family member's, or maybe someone that you're working with. Or time felt short and you felt really rushed. Or you felt like you were about to have an uncomfortable conversation, or maybe, ooh, did I just say the wrong thing? And the reality is, this is probably not thinking back too far. It's probably almost every shift that one of these things is happening. And the reality is, I can think back to just the other shift. I was working at a community site, and a 50-year-old guy is boarding for hours for chest pain. His wife comes in yelling at the whole department, saying, I'm going to leave AMA with him because y'all, if he's just sitting here, like I can take better care of my husband at home. Like he hasn't even been able to eat anything. He's hungry. He hasn't gone to the bathroom. Like he has to pee. Like no one's even watching him here. He was even off the monitors. He could have coded and I could have done CPR on him. So in that moment, I noticed, blood starts to boil a little bit. The staff starts ramping up their emotions. And in that moment, I actually noticed, though, I'm okay because I've actually spent a lot of time now working on communication skills, and I look forward to interacting with folks in this space and trying to kind of like hear their story and kind of get to the bottom of this and calm. But it takes some skills to get there. And the reality is that we talk a lot about clinical knowledge skills, but a lot of the things that cause some stress in our daily lives are communication challenges. And communication is actually the procedure that we practice most commonly in emergency medicine, but we don't typically approach it the same way that we approach putting in central lines or intubating a patient. We don't have the same training for it. And these skills are teachable. So that's what we're hoping to cover 3 quick skills today that are teachable skills that you can employ right now in your next shift. We're going to be covering 3 objectives today. We're going to be talking about shared decision-making, naming and legitimizing emotions, and practicing a framework to help us disclose bad news or difficult news. We'll start with shared decision-making. And let's start off with a case. You're seeing a 26-year-old male who's presenting for abdominal pain that he's been having for a few hours. On his exam, you notice some nonspecific, pretty mild mid-abdominal pain, and his vital signs are normal, and the only thing that's abnormal in his blood work is a white count of 13. And he initially came in thinking that he needed a CT for appendicitis, but when he was told this might take a few hours in the emergency department, he's now saying he's feeling better and he wants to go home. So what is shared decision-making? Shared decision-making is when you, the clinician, present and describe various management options that are all medically reasonable, and get the patient's input on what they feel is the best option for them. You really need to communicate concisely 3 different things, and that's what the options are, why they are reasonable, and what the patient's perspective is on those options. So thinking to our 26-year-old male, this is an example of using a framework that Greg and I call the some people, other people framework to present some shared decision-making options. So you could say to this 26-year-old male, some people tell me that they'd rather avoid the radiation and go home right now, even if there's a bit of uncertainty about the possibility of appendicitis, and you can always come back if things get worse. Other people tell me that they'd really like to get a more definitive answer while they're here, even if it takes some extra time and exposes them to radiation. What are your thoughts? You're going to practice this right now with the person sitting next to you. So you have a 5-year-old that's coming in with a closed head injury after a scooter fall. The patient vomited once and otherwise has a normal exam and behavior, and per PCARN guidelines, you're recommending observation. The mom looks intensely nervous, though, about the fact that their kid could have a head bleed because her friend's kid suffered a head bleed when they had an injury recently from a fall from a bicycle. So how could you, with the person sitting next to you, use the some people, other people framework to initiate a shared decision-making conversation about observation versus CT? And take about no more than 1 minute to have a conversation with your partner about how you might use some people, other people to have this conversation. Mm-hmm. Yep. Yeah. I have a minute on. About 20 seconds. Oh, perfect. Okay, perfect. Yeah, I'm just going to move forward. I'm not going to ask for this one. Maybe at the end. Yeah. Time? Okay. All right, it's okay if you guys didn't finish your conversations. One possible option that you could have said is something along the lines of, some parents prefer to have us observe their child in the emergency department as their risk of serious injury is really low, in fact, under 1%, and their risks of having a CT scan. Other parents say they're not going to be able to stop worrying about their child, even after a careful observation period, unless they have a definitive answer, even if the risk of serious injury is really low, and even if it means radiation exposure for your kid. What are your thoughts? And so notice that this hits all of the components of shared decision-making, which is offering the options, explaining why they're reasonable, and asking the patient's perspective. And those are the 3 things that you're really wanting to hit. With this some people, other people framework, people notice that it's a pretty easy way to frame and legitimize other options, and it actually happens pretty quickly. And also it's an effective framing, legitimizes the options, like I mentioned, and invites the patient perspective then at the end. We'll move on to Greg's part.
All right, so here's something that I was terrible at when I was in the emergency department. Something we've spent a lot of time on in palliative care, but I think is really like a 2-second skill when you use it. So it is about naming and legitimizing emotions, which we hear all the time, and they're always wrapped up in more cognitive statements like, there must be something else you can do, or I can't believe I don't have an answer. So starting with the case again. So a 24-year-old female presents with 6 months of generalized abdominal pain, comes and goes. She was supposed to go to GI clinic. It was canceled, so she came to the ED instead. We had this all the time when I was in the ER. Essentially, her exam and labs are unrevealing and normal. Right when you're about to discharge her, mom runs in and says, this has gone on for too long. There's got to be something wrong, doctor. You had better give us answers. So here's what I might have said in my past life. I'm so sorry the GI doctor canceled on you today. We didn't find any emergencies on our workup. We do recommend that you follow up in the GI clinic. So we are giving here a cognitive response and plan to an emotion.
And so the studies demonstrate that we think we're a lot better at conveying empathy than we actually are. Numerous studies demonstrate this. But there's good reason for it. There are several barriers to why we have a hard time naming our patients' emotions or even our colleagues' emotions. And I'll give 3 examples of why that might be. One is that we're worried we have to fix what is commonly a negative emotion that our patients are having. People come into the emergency department with fear, anxiety, sadness, grief, and we're worried we have to fix that emotion. The reality is that we don't actually need to fix negative emotions. A second reason why it's really hard for us to name emotions and respond empathetically is because we're socialized to stay professional and to talk about clinical knowledge, and that getting into matters of the heart might feel a little vague or uncomfortable. And the reality is that when patients are asked what they care about most in their clinicians, empathy is one of, if not the most important things that they mention that they care about. So it matters to our patients, so it should really matter to us. And then the third thing is that we worry that when we're entering this emotional realm, that we're gonna open Pandora's box, or a whole can of worms gonna be open. It's gonna negatively affect our empathy. And actually, studies have shown that responding with an explicit verbal empathetic statement shortens visits. Now, these studies were done in the outpatient setting, but this is because when someone has emotional distress, they keep cycling on it until it's addressed. And so it can save you time. You don't need to fix the negative emotion, and you actually are doing something that the patient cares almost most about in their medical stay.
So one thing we'll be talking about just in this response, and like I said, that was the one I might have given prior to thinking about this, is just using a more specific word than sorry. So some research on this. So there's this thing called amygdala hijacking. The short version of this is in business literature, management literature, neuro literature, and they recently, like a decade ago, did some fMRI studies that all kind of prove this same thing out, which is that when our amygdala is firing, so our emotions are high, we cannot think cognitively about decisions, which is what we need to do in the emergency department, is help them make a decision, help make a disposition, et cetera. And so actually the most powerful tool to turn that amygdala off is actually to name the emotion. It's called affect labeling in the literature. It shows up on fMRI studies where the amygdala is on, the frontal cortex is essentially off. The amygdala turns off when you name that emotion, and the frontal cortex turns back on. So what that really means is that you help people think when you name their emotion. So what emotion might this patient be feeling? This has gone on too long, doctor. There must be something wrong, and you had better give us answers. I'm putting one up here that I think is reasonable. You don't know exactly what they're thinking, but you say, gosh, it must be so frustrating to have pain that's gone on for a year without anything to pin it on. And pause. So in the ED, right, our instinct is to run all the time. And I think sometimes we run through these, but the pause puts an exclamation point on it and also allows a simmer down period. It's got to be so frustrating. I'm so sorry that we don't have an answer. You have been multiple times to the doctor, and I don't have anything, else that I can add diagnostically. Pause. So the second part of this, so you name the emotion, but you also need to legitimize it. So you call it out, but then say why. So it's really frustrating to have pain for so long and not have answers. I can see how much you care about your daughter and your daughter's health. Would it be okay if I shared what we did today? And I'd be curious to learn what you're most worried about. I don't know, that took me maybe 7 seconds, let's say. I bet that shortcutted 2 or 3 minutes of conversation and probably made the patient and daughter leave a lot happier.
All right, so we're going to move to practicing this. So we have 3 drills in which the only task that you have is to name the emotion in a sentence and pause. That's the only task that you have at hand. We're going to do 3 quick cases. So a patient that's been on hospice care arrives after a family revokes the hospice in the setting of a sudden decline in their health. Has anyone seen this happen in their ED? Okay. They arrive and the family member states, I don't know what to do. He doesn't even want to be here. Turn to your partner and just say, what's the emotion? Name it in a sentence and pause. All right, what were some of the emotions that were named in your groups? Worried. Okay, I hear worried. Scared. So, Greg, I'm going to be the family member now. Why don't you respond to me? I don't know what to do. He doesn't even want to be here.
It's got to be so overwhelming with a family member so sick and not knowing what to do.
Exactly. Okay.
All right, drill number 2. Flip partners. So whoever was responding, it'll be the other person this time. So a patient with abdominal pain has a normal CT scan and an otherwise normal workup, and you're planning for discharge. You go into the room and the patient tells you, "This is useless. Y'all don't even know what you're doing here."
What emotions are you naming here for the patient's family member? What might this person be feeling? Frustrated, I hear? Yeah. Fearful. Oh, I love that one.
Well, this was useless. Y'all don't know what you're doing.
And it sounds like it might be pretty frightening to have symptoms that we're not sure what the cause is. All right, last one. A colleague returns from a cone. Note that we just did 2 patient examples, or a patient family member, and now we're actually going to do a colleague. This works with colleagues too. We all have emotions, right? So a colleague returns from a code. Oh, yeah.
Really quickly jump in to say that this is actually me. I just want to point that out. Like in real life, this was me back. Yeah.
So Greg returns from a code where a patient died. He blankly looks at you and says, "I can't believe that vague chest pain was actually an aortic dissection." Turn to your colleague, and what are the emotions here?
Anyone want to call him out? I heard one. Shock, I think I heard you say. Anyone else? Overwhelm, unsettling.
So, guilty.
Absolutely.
Yes.
Shame is so common in medicine.
Yeah. So, Greg, I can't believe that vague chest pain was actually an aortic dissection.
It's got to be shocking to have these vague symptoms show up as the thing that you're supposed to detect on arrival at the ED.
All right.
So this one's near and dear to my heart. This is like the one line that I think has gotten me like 30% of my entire fellowship training in palliative care. And I'm sharing it with you here, so you are 30% fellowship trained right now. Did you, Matt? So we're going to get to it, but the short version of this is it's a framework to disclose bad news that aligns you with the patient. Case, 64-year-old with severe dementia, trach and peg, recent large stroke, presents with severe sepsis and concern for aspiration, and this is the 4th time you're seeing him in the ED in 6 weeks. The patient's partner states to you, "Tell me what's going on. I don't want her to suffer." So here's the framework. I hope, I worry, I wonder. I'm going to say it a few times just so y'all remember it, because I think you can take this back to the next ED shift probably somewhere. I hope that we can get her through this episode of pneumonia, aligning with family. I hope we are on the same side. I am on the same side as the patient. I want it to get better too. I worry that this is going to keep happening, right? This is the 4th time in 6 weeks. So you are sharing hard news directly. I worry this is going to keep happening. You're not, oh, maybe we'll get through this, right? You're saying, I am worried this isn't going to go the way that we think. But it sounds very much patient aligned because it is. I wonder if you've thought about what she might want if we couldn't fix the reason she's having these pneumonias so often. Okay, so let me just back up and do it all at once because it's very quick and I think it's usually very effective. I really hope we can get her through this episode of pneumonia, but I am so worried. This is the 4th time, and I worry this is going to keep happening. I wonder if you've thought about what she might want in a situation where we can't stop this from happening again.
Note the pause at the end of that. It's important to leave space for a response there.
So here's your practice. I hope, I worry, I wonder. You're caring for a 44-year-old who reports uncontrolled abdominal pain in the setting of stage 4 metastatic cancer. She's failed 3 lines of chemotherapy and is screaming in pain. You give her pain meds and she starts becoming sedated. Her family asks you, "Doctor, I don't know what to do." Turn to your partner. Take a few seconds to collect your thoughts. I hope, I worry, I wonder. All right, here's a possible response. I bet that some of y'all said some of these things better than is written up here, but just this is a suggestion. So, I wish your wife's cancer was curable and her pain were controlled. We had hoped we could find a good medication plan that would keep her both comfortable and alert. I worry she's dying from her cancer and that she's uncomfortable because we're holding pain medicines to keep her alert. I wonder if more aggressively treating her pain, even if it means less time alive, would allow her to die comfortably and peacefully. Again, so you've taken like an entire goals of care conversation that usually would come in pieces with information like, well, you know, we can't give her more pain meds, or we can, but like if we do, I just want to let you know that there's a risk of dying. You know, those conversations are both long and clunky. This probably took me, I don't know, again, like 20 or 30 seconds, and I think it gets you like 70% of the mileage of like a much longer conversation. So I think if I, again, had to repeat this framework one more time, I hope, I wish, I wonder, this is really like most of the magic of getting an ER goals of care conversation, ER disclosing of bad news. And if you need more, it's probably time for a palliative care consult, because the longer version of this is like 30 minutes. All right. So today, 3 goals. Number 1, some people, other people for shared decision making. Number 2, when you hear a cognitive statement that feels hard, take 1 second to say, is there an emotion behind this? And if so, can I name it? And I think that one tool to name emotions if you don't really know, instead of saying I'm sorry, which feels kind of token, so you can say something like, this is really tough. And people will usually name the emotion for you. It is tough. I've been waiting for 6 hours, doctor. And you hear, they're impatient. So you can get the emotion by naming just the general feeling of like, this is hard or tough or difficult. And then this I hope, I worry, I wonder framework.
Thanks. I think we have a few minutes for questions before the next. Oh, yeah.
Do you just, So last shift, patient came in with a plan. They had trigeminal neuralgia, and they said, the last doctor I went to a freestanding. They said, you guys will admit me to get my pain under control. And so, she was there with her mom, and this was their goal, which was to be admitted for pain control. And that was not my goal.
So this is a really great case, and this is an example of actually when several of these tools can be utilized, namely the naming emotion and legitimizing it, the second thing we talked about, and also it's actually disclosing bad news to the patient too. So it's an I wish, I worry, I wonder statement. Do you have any additional
Do you want us to try?
Yeah, okay.
So, is this working?
Yeah.
Okay, sorry. Well, first of all, I can't imagine how frustrating it must be to have a painful diagnosis with no treatment, be told to come here for a treatment that I'm not sure that we're going to be able to offer today. Not because we don't want to, but because we're not trained to do that procedure. I really hope that with some medications today we can get your pain under better control. I'm a little worried that the treatment you need isn't something we can do here in the ED, but I can set you up with some resources to hopefully address it. I wonder if you have any ways that you've been told to reach out more urgently to a neurosurgeon. We can try to do that here too.
Yeah. And I love a lot of the components of what was in your statement. Things that I heard were naming an emotion and legitimizing it. So you're saying it must be so frustrating to have a painful condition for so long and to have a unmet expectation of coming here and expecting to be admitted, and now I'm saying you might not be admitted. Important part here is like pause now. What do they respond with? And then moving on to the...
There's often, you'll realize too, if you name the emotion, just let it sit, people will name things that you never expected. They might say, oh my God, like, I'm just so worried it's cancer, right? And you never know that's coming until you kind of like let it sit.
Or I have a big work presentation tomorrow. There's no way I can do that. And like what they really wanted was like a work note or something. So there's like, when you let it sit and allow space to expand, there's usually other ways that you can align with the patient and be like, I wonder if there's other ways that we can work together, which is a statement of support, which is something we didn't talk about. I wonder if there's other ways that we could work together to figure out a really good plan, a safe and effective plan.
And there's obviously a lot of other communication tools. I was trying to just illustrate like the two ones that we use today to try to answer a question like that. But that's tough.
Yeah.
That's absolutely tough. And that is what absolutely, I'd point out what Gretchen said. Bad news sometimes means we're not giving you what you think you're getting here.
We had one of our cases that we were going to talk about was like someone that comes in asking for a GI consult, and like that's not going to happen at Seton, Maine, right? So if they're not actually like bleeding, and it's like, right. And so I wish that I really wish that, or like I'm hoping that we can help control your symptoms today. I'm worried that we're not going to have a GI consultation coming to the emergency department because they have very strict requirements for when they come in. I'm wondering if we can work together on a pain management plan and follow-up plan that will allow us to help your symptoms and make you feel like you have a good follow-up.
I think we better hand off for the 8:30.
Thank you all.
Thank you so much for coming.
Yeah,
we'll
we'll just
walk out of the crowd a little bit even too.
yeah.
And don't mind turn back the point at this point because it's gonna be awkward if we're up here with 6 people. If there are 100 people, but might as well walk out this way. Get closer.
Sounds just like look right in that chain.
Yeah.
Are you gonna hold your coffee or?
Coffee. I can't let it go.
Here's your clicker.
This one. Okay. We'll give it another 20 seconds until people show up.
So go sit next to Matt.
Yeah.
Actually be in the audience.
You'll be a plant.
Yeah, I have a question. How expensive was it?
So thank you, everyone, for waking up early and coming to the Friday 8:30 a.m. lecture on the virtual reality. Sorry, I lost my voice somehow overnight. I did not go to the party, so it is not because of the Rams party, I promise. But my name is Thomas Yang. I'm one of the assistant program directors for emergency medicine residency, and I'm also a simulation person for the Department of EM at the Medical College of Wisconsin. This is Dr. Wilbanks. He's our director for the student advisement, and he was also the M3 clerkship director. And this is Dr. Samuel Corbo. He's also my counterpart in residency, assistant program director, and a co-M4 clerkship director. So they're from the UME side, I'm from the GME side, but we're gonna talk about virtual reality, talking nuts and bolts of the VR curriculum. So from somebody who does simulation, I mean, Dr. Baccio is here, who also does simulation here. Thanks for coming. That there's some pros and cons of simulation, right? It is versatile. It can, it gives you tactile feedback, so from procedural training. It is also very easy to replicate the cases, and you can use it in any kind of simulation lab you want to. However, as we know that these simulation labs are also expensive, as a simulation center director, it costs multi-million dollars just to maintain the simulation mannequins, and this is besides the HR portion. Just the software, hardware costs multi-million dollars, but it's also stationary. Like it's very hard to move a mannequin from point A to point B. You can use test trainers, but it's very hard. So we're gonna talk about some of the other modalities of simulation, such as the virtual reality, mixed reality, and augmented reality. And Dr. Wilbanks and Dr. Corbo will be able to talk about what we did with the virtual reality. So in virtual reality simulation, what's been used right now in medical education is actually being taught for preventative medicine or giving breaking bad news, giving like feedback, teaching empathy in medical education. And what virtual reality means is that pretty much you're in a virtual environment. So I'm going to give you 2 more terms, and it can be really, really confusing. You're like, well, this could be VR, this could be AR, this could be MR, but you just have to keep it simple. Virtual reality means using virtual platform. So virtual platform meaning virtual environment, not the real environment. What mixed reality is, that what that means is that you're using a virtual platform and also a real platform. So what that means is that you can use the haptic feedback that virtual reality, such as Oculus or any kind of other devices can provide you, but you can use on the real environment as well. So currently in medical education, what's being taught is a lot of neurosurgery or surgery simulation has been using in mixed reality thus far. Then comes the AR. I know there's a lot of R's in here, but augmented reality is, about a few years ago, I think general population found out about augmented reality through this, picture on the right, Pokemon. Yeah, you go to the street, remember, like you find a Pokemon, you try to catch them in the real street. So that's one example of augmented reality. But in medical education, what's been used in augmented reality is actually like anatomy. So in undergraduate medical education, they've been using such as a Google Glass So what you would wear, and then there would be a 3D object that pops up, and you can rotate the object that is in front of you in the real environment, and you can study the the small, even detailed anatomy portion of, let's say, a heart or a liver or of a body using those using the augmented reality glasses. So this is pretty much the general diagram of what that means. So the XR, which I didn't talk about, it encompasses all three, but the VR, MR, and augmented reality is on different spectrums of things. And I'm going to hand over to Dr. Wilbanks and Dr. Corbo, because what we did is a little bit different, because the virtual reality, what we did is not just teaching empathy, but also teaching some resuscitation cases for procedures and all.
Great. So our institution received a grant in order to acquire virtual reality equipment and then use it in education. So what does that actually look like? Most people are familiar with virtual reality, at least knowing what the headset looks like. It's a big funny thing you stick on your head. It sticks out in front of your eyes. They weigh about a pound to a pound and a half. They can be pretty heavy, but generally they're very comfortable. They're meant to be worn. You can wear them for hours on end as long as your eyes don't get tired or you get motion sick, but they're highly customizable in terms of fitting to the shape of the user's head, and it can adjust. You can adjust the eyesight based off of your glasses prescription, contacts prescription. Some of them are more friendly to wear glasses on, and then you can also adjust like the distance between the lenses. So you really want a highly customizable, well-fit headset, because otherwise even the smallest distortion in what you're seeing visually could cause a lot of motion sickness and make the user uncomfortable. So this is the image that gets projected to either eye from the virtual reality system. There's a lot of aberration because as it goes through the lenses, it'll correct for that. So the lenses that are actually used are what's called a Fresnel lens. These lenses were originally invented in the 1800s to put in lighthouses. Basically, they can take a wide arc of light and project it into a beam, which is great for keeping ships off the coastline, but it's also great for taking a small picture being projected by the headset and then making it look like the user has a very wide field of view. So this is what our headset looks like, kind of viewed from an angle, and you can see all the ridges in that special lens, which also helps with having lenses designed like this. Also helps with the overall weight. You can have a much smaller, much more sleek lens that's able to do more than a larger lens would be doing with a lot more weight. Every VR headset's going to have some kind of handset, and while they can vary from model to model, in general, the inputs are pretty standard. So there's a thumbstick, which is similar to any modern gaming console if anybody is familiar with video games. There's a couple of input buttons. Ours are labeled A and B. There's a grip button for my middle finger, and then trigger finger as well for the index. And you can interact with the virtual space using a variety of these inputs, and I'll show you what that looks like later. Now, you're wearing this headset, again, fully virtual, 100% environment, so you're not seeing the room around you. This would be a great place to do virtual reality because I can take 20 steps before I run into a chair. If you're at home or in a classroom or there's a few more obstacles, then you really want to make sure the user stays safe. So while the headsets are projecting images to your eyes, most of them also have cameras affixed to the outside that can project the environment that you're in so that you can use your controllers, and when you start to use the equipment in a new space, you can interact and set a boundary that the headsets are keeping track of in the background, and when you approach that, you're going to see, it's going to give you feedback saying you're about to leave your safe space. There's a lot of different varieties of equipment. In general, there are a couple of things to balance, right? You can have a very portable system, you can have a very cheap system, or you can have a very powerful system. And it's hard to get all three of those in perfect harmony. in general, for something where you want high performance, something where you have a lot of learners in the same space, you're going to require a lot of processing power. And so that's going to require not necessarily your all-in-one headset that just works right out of the box. You're going to want something that's connected to a high-end gaming PC, something with high horsepower under the hood. And probably has some neon lights for decoration because it's meant to be bought by people playing. I don't know. What do the kids play? Fortnite? Or something? Yeah, I don't know. But the more generally, the more money you spend, the higher the resolution your images are, the less lag there's going to be, and everything's going to look a lot smoother. So this is what our setup looks like. We have an Alienware PC. It's very heavy, but very powerful. Our headset are 2 controllers, and then those are the cords that connect the headset to the laptop. So it's one of those things where you can... you do get kind of used to having the cords behind you, but if you're not careful, you can wrap yourself up and potentially pull your laptop off. I'm not saying that happened once, but I am saying that the laptop wasn't harmed, and I was much more careful the next time. These are a couple of examples. Most people, I think, are familiar with the fact that Facebook, now Meta, bought Oculus, and you guys heard about the Oculus Quest, now the Meta Quest. It's an all-in-one, it costs $350. It's not really meant for, it's meant for personal gaming use. The one down below, the HP, that's the version that we have. It's $550 and then requires the use of a PC that it's tethered to. And then the one in the top right is well over $1,000. It's an HTC Vive, but you get a pretty premium experience. Let's see. So we bought 5 headsets, 5 Alienware brand gaming PCs, which are really sleek to look at. But overall, this is a very expensive undertaking, and we spent about $20,000 just on equipment alone. Now, we're also working with a company called Acadicus in order to create virtual content. But in our space, in the emergency medicine space, there wasn't really a lot of content that we could have available to us and then use. So we had to create a case. And I'll hand it over to Dr. Corbo about what that process was like.
And to Dr. Wilbank's point too, it is technology it's very submersive, and you really feel like you're in that space. He didn't harm a laptop. I harmed a lamp in my living room when my wife and I were just toying with technology to try to learn what it was like and to get a feel for it. So I'm going to talk about what it went through for us creating a case. And so Dr. Wilbanks mentioned the group we were working with, and essentially. How this all came about was the medical school got a grant to explore this technology through Acadicus. They reached out to us in emergency medicine to create the case, and so they brought the hardware and a checkbook for us to sort of toy with and create kind of what we wanted to see what was possible. So we were debating what we wanted to do for a case, and so we knew we wanted to do someone who was a sick patient, right? Like, we're not going to do a cellulitis case with this really cool technology. We really wanted to stretch it. We want something that was someone who could maybe crash or be more dynamic, maybe would involve procedures, really kind of stretch the technology. So something like neck fash would be, or maybe we could have it creeping up and blistering in front of us, which would be really difficult to create outside of that space. And so we wanted to definitely do, a sicker patient. 2, we wanted something like that was more difficult that we weren't, we couldn't already do well in the sim lab. So like I said, if we can control everything down to what the wallpaper looks like, why not, really kind of push the technology, see what we can do with it. That is maybe different than what we were already doing. And so we wanted to maybe do something that would be more challenging. And so we thought of things like, a stroke patient, for example. Like, it's kind of challenging to not be obvious with more subtle stroke signs even with a really well-trained SP. And so we wanted to really see where we could push this and what we could kind of toss in. Like, could we have like a pallor slider so someone's getting, bleeding out, getting more and more pale as they're in front of the learner, and see if they pick up on those more subtle cues. Like I said, we wanted something that was dynamic. We want to stress our learners. We wanted to make it fun. And when we thought about how we want to present this to maybe like a whole class of residents, we would maybe, instead of having them run a case in the sim lab in front of the entire class, we'd have our learners out in the sim area walking through a case while the rest of the program is watching them essentially on TV go through the virtual world and perform these cases. And so we wanted something that would be that would be challenging, would give the learners different tasks to complete and really stretch them too. And then some procedures and tasks potentially. And again, just to sort of see what we could do with technology and what was useful and what was what was not. And so we landed with cirrhotic GI bleed, and we'll talk about why. So some of this, I personally love teaching about GI bleed, and so that's maybe the reason I really wanted to push for it. But for one, we could scale to learner levels. Dr. Yang mentioned I am an M4 clerks director as well as an APD. I teach all levels. This is going to be really scalable. So I could do someone who has, maybe a little bit of instability or, maybe a little sick and teach my M4s about GI bleed. I can then ramp it up and have just like my Mount Vesuvius, hematemesis case with our near graduate 3s. And so it did seem like something we could scale, so we create one case to be useful for a lot of many different levels of learner. 2, we could use point of care ultrasound, see what that showed us. If this patient has ascites, that might change how we manage them. If they, have a collapsing IVC, that might tell us something about their volume status and might change, what our learners are doing. 3, potentially could do something with airway. This is a tough airway to simulate. I ultimately don't think that this is the best, that VR is maybe the best use for at least airway teaching as it stands. But I thought, okay, these GI bleed cases are pretty labor intensive to create, so maybe we could find something to have them at least walk through, a challenging hematemesis airway. And then this is where, one thing I thought would be really unique, it's not the sexiest of procedures, but technically balloon tamponade is a halo procedure. Not many people have done balloon tamponade in the ED, or not doing it very often. It's not much different than an oropharyngeal tube, but at the same time, like there's some steps you have to walk through. It's usually being performed in a high stakes environment, and walking through the steps is probably the most challenging part of placing that. And so we thought there'd be some potential using that. So what are the challenges we face? It is expensive. So Dr. Wilbanks mentioned there's about a $20,000 buy-in by the institution just for the hardware alone. And then, creating the case itself costs money. So it's expensive. 2, it costs a lot of money. And so it is expensive. Our case, actually, at least through the grant that paid for it, but a catechist charged, it was like roughly $10,000 to put together this case when it was all said and done. And I don't know if I mentioned this yet, but $3 signs, it costs a lot of money. And so it costs, at least utilizing grant money, but it was $10,000 to buy the case. That was at an 80% discount to let them use that case to put it in the library for future learners. And so it is at this time, and I think this will change, but it is pretty cost intensive. And so part of the reason why everything that you put into the case costs money, and it's scaled based on the complexity. And so, but things like having pulse ox, having an IV, having a blood pressure cuff to really make it realistic, that all adds up. But like things, we thought, okay, we could make them more jaundiced. We could have a pail in the slider. That's more complex, and that to the point where it became essentially too expensive for us to utilize. The balloon tamponade, which I talked about earlier, which is one of the reasons I thought this would be a good case, was so expensive it was probably not even feasible to do, and so it was tossed from our case. So not even possible. We took out things like labels for octreotide, protonics, and a toggle. And so it does, everything adds up to really kind of get everything you want out of it. 2, it takes a lot of time. We spent about 6 months after we learned to use technology just meeting with the group to get an initial case going, make some revisions until we had our final product. And then I don't know if I mentioned this yet, but it's expensive. And then last but not least, the group we worked with was great. They were, they really were good at communicating with us, but there's a lot of disconnect between what we know would be effective for our learners and what they what they were really excited about, what they thought that we could use. And so 2 examples of that. For one, like they're really excited about airway. You just don't get the tactile feedback you would. And so we knew that airway, like intubating, would not be probably of value for our case. The other, another example, they when they were showing us off the first time, they were really, really excited. We were looking in horror. They were showing us how we could do suture repair on a patient with an abdominal wound in our department. So the patient's laying there, an abdominal wound, and they were basically like having us walk through the steps. And we did to work with them, but like just stapling up an abdominal wound on a patient who, we're probably like stapling through fascia, through bowel, who knows. But they're a technology company. They don't quite get what maybe we really need in terms of truly delivering teaching points for our learners. So at that, I'm going to hand over to Dr. Wilbanks, who's going to show our case.
Yeah, so it became pretty clear that doing anything procedurally was going to be very difficult to replicate in a manner that was going to be helpful for learners. So ultimately, what we did work with a catechist, and they actually gave us even more of a discount. The overall buy-in from our medical school was about $5,000, because like some of the things that we were suggesting to change to our patient model, they wanted to incorporate as they were making their like general model more more complex. So, and I'll show you like what our scenario actually looks like. Let's see. So this is a live feed of myself in the virtual reality environment. I have two hands. I am teleporting around the room using the thumbstick. Basically, if you've got an emergency department room that's 30 feet by however much, you can't really walk in most spaces like you would in real life. So you teleport around the room using the inputs from your controller. So this is me coming to the side of the patient's bed, and. Yeah. I try to be like really still with my head and slow with my movements. But apologies to anyone who gets motion sick. It's a lot more comfortable when you're actually in the environment. But that's our sim person. Here I am using the inputs from the hand controllers to manipulate a piece of equipment. This is a pulse oximeter, so I can pass it from hand to hand and then apply it to the patient's finger. That menu off to the side is a way that I can change the patient's positioning in bed in real time if I want the patient sitting up or down, or if I want the bed up or bed down, basically mimicking what you might do in a real emergency department. This is the simulation manager. So in a situation where we have learners in the environment, but one person is facilitating and they are changing the vital signs, this is the input that only I see, that the learners don't see, that allow me to manipulate vital signs, increase or decrease the heart rate, SpO2, and then change like what gets put up on the vital sign monitor there. So right now I don't have any of the waveforms up, but I'm about to go in and change that so those can so that those can come up. And it can also be set towards, as soon as you put the SpO2, put their pulse ox on or put their blood pressure cuff on, it'll automatically display, or I can just have it display without requiring that equipment. So much like you would do in your control room in a high fidelity sim situation. Here I have a stethoscope that I'm placing on the various sockets over this patient's chest. The sound quality is pretty high fidelity, so I can place it over his chest and listen to heartbeat, breath sounds, and then through the simulation manager menu that I previously showed, and I'll show you on the next slide, you can give them a murmur, you can give them crackles, you can give them wheezes, you can have breath sounds absent. You can really change a lot of the things about this patient. So kind of what started as a GI bleed case ended up growing into something that could be customizable for a variety of clinical scenarios. So here I am manipulating the patient's breath sounds. So all of those yellow dots correspond to a socket on the patient's back that I can change what is being listened to. It's hard to see the resolution blown up like this, but on the left side, all of those breath sounds are normal, and then I'm changing them to coarse crackles in the basis, and then to fine crackles, as if a patient were in congestive heart failure. There's a lot of variety that you can that we can manipulate our mannequin with, including lower extremity edema. And a lot of this was iterated by a Catechus software company as how they wanted their technology to grow, and was not. When we first started talking to them 2 years ago, this was nowhere near what they were able to do. But then I think they got a lot of ideas just working with us and then helping us with our case. So we can really take and we do have a jaundice slider now that they were able to add. We can do jaundice and pallor, but I don't have a picture of that, unfortunately. One thing that was helpful from a procedural standpoint that we wanted to do, that Dr. Corbo had mentioned, is the use of ultrasound. So what we have is you can grab our ultrasound probe and then socket it to this patient's left lower quadrant, and then we were able to put real video of a real ultrasound into the case that would pop up on the ultrasound machine. So we could do this for a variety of things if we wanted to have it be a positive fast, have it be we could do lung X-ray, really any ultrasound, and I think that's one of the values of going forward from a procedural standpoint. One thing that would be helpful, but we had initially tried to create something where we can do a paracentesis, but the mechanics involved of manipulating syringes with those awkward controllers, it just doesn't really correlate one-to-one. So we kind of abandoned the thought of doing significant procedures on this gentleman. Dr. Corbo mentioned it takes a lot of time to do all this, and we had initially hoped that by the time this talk came around, we had a robust run-through with our virtual reality curriculum. That has not been the case, but we have had a lot of learners go through and look at our SimMan just in terms of, are you able to comfortably move around the environment? Is this exciting for you? Do you think that there's benefit? And they really enjoyed it. So I had 5 medical students last week just interact with our SimMan for about an hour, and we played around with it, and no one got significantly motion sick. They all really loved it, and they really liked the fact that we could manipulate him to show various pathology like asthma with significant wheezing and diminished breath sounds, or congestive heart failure. And they felt that the quality of the breath sounds and heart sounds, for instance, were a lot higher, was a lot better than what you'd have on a sim mannequin. That can sometimes be difficult to hear or differentiate between various sounds. So that was a nice benefit. And then a lot of our learners had already used VR previously. I had never used VR when we started playing around with this technology. Motion sensitivity for some faculty, I would say. None of our students seem to be bothered by it. But I think the biggest thing is that this is all in its nascent stages, and just by working with this company, we were able to see how their capabilities grew over the course of a year. But I'm sure 2 years from now it's going to be significantly different. But once the content's created, then it's going to be easier to utilize, but the hard part is actually creating it. And so we went through a lot of growing pains and frustrations to actually put something together that overall only kind of worked, but shows a lot of hope and has certain possibilities for the future. But maybe less so from a strictly procedural standpoint, which is probably best left to high-fidelity simulation, task trainers, et cetera. So that part was still pretty clunky. Overall, we think that there's a lot of potential here, but it's probably, at least in our experience, isn't extremely ready for being a robust part of our simulation curriculum. But we're happy to follow it along the way. And eventually, as the technology continues to grow, the fidelity is going to get higher, the cost is going to go down, there's going to be fewer barriers to entry, and we just need more content out there, which is on its way, I guess. Let's see. Well, we'll take any questions if you guys have. Oh, never mind. I think we're done.
standing around this area for the gym. There's also one more wireless mic right there. Okay.
Hey guys, I know it's early. This is a workshop, so you are actually going to be practicing negotiations, so we would love it if people came forward. But the most important thing is that you find a friend. Okay, so you're actually negotiating with someone, so I need you guys to partner up with someone that you're going to go through a two-part negotiation with. So look around, find a happy face. And for our add an odd number, we'll recruit people. I'll go outside and pull them in. It's not. Yeah. Welcome. Thanks for coming. We're doing a workshop, and so you'll actually be negotiating, practicing. So if you would love to come up and find a partner, we would love for you guys to partner up with somebody. Great.
Sure. So we'll go ahead and get started. And as people come in, we can have them partner up. So I'm Nicole McCoyne. I'm the chair of emergency medicine at Ochsner Medical Center in New Orleans. Thanks, Carmen. This is Dr. Carmen Wolf. She's the residency program director of Skyline Emergency Medicine in Nashville, Tennessee. And so we're going to talk to you all today about negotiation, particularly how gender may affect negotiation. And we want to thank the AWEM group and the Faculty Development Committee for sponsoring our talk. So there's a number of factors that may affect negotiation. Obviously, we're going to talk today specifically about gender a bit, but keep in mind that there's other factors as well: sexual orientation, socioeconomic status, that are ethnicity, and all of those factors can actually impact our success in negotiation. And so the question becomes, why is that? And so just to give a little bit of background on the research that's done behind negotiation, decades ago, there was a thought that the concepts behind why women weren't as successful at negotiation was because we didn't ask. And that we had certain traits, kind of stereotypically, collectively, that inhibited us from being successful or hindered us from being successful at negotiation. For example, that we have a higher external locus of control, so we feel a little bit more helpless as a gender to the success and the ongoings of negotiation, that we're willing to accept less, all of these different factors. Well, it turns out, and the response was, you need to just get out there and ask. So there were books entitled Ask More, or Why Don't Women Don't Ask, with the premise that when we don't, that we would have obviously reduced lifetime earnings that are impacted over time, over and over again, and by the end of our career are very significant. And that also downstream effects, we're not getting as much enjoyment out of our work, we're not getting the promotions that we should be getting, and that over time that could have a really negative effect on not only our health and our own selves, but also our institutions. So, turns out that decades later, there was some more research that came about. And we actually are asking. Problem is, we're not getting. So Harvard Business Review, a number of other articles, but the one that we cited here, talk about how we are asking, but there are so many biases out there that we aren't getting the same results. And so the whole point of today is to really sit down and say, what can we do to do it the very best we can so that we can have as much success? Because we're not going to fix the biases in this hour in this room. But we do have control over a lot of factors that could potentially make our negotiations more successful. So this is a slew of texts and articles and books that we have used. Another one that I really like is Getting More by Stuart Diamond. Getting to Yes is a really popular text. All of these could be really helpful. We've read all of these, gone to formal courses, and learned from some of these folks. And so it's been really interesting along the journey. We've picked up some pearls, and hopefully they'll help you. All right. Is it working? Here, you want this one?
All right, so we're going to start your workshop. So the workshop has two parts. For those who've come in since we started, this is an active workshop. So you'll actually be practicing negotiating with someone. So we'd love for you to partner up. We've got partners here. I'm not sure if you guys would like to partner the two single individuals here, but we are actually going to be practicing negotiating with one another. Now you'll have different color sheets. You have different roles. And so you'll read your introduction to who you are. And then there will be a first part of the negotiation. So one of you is a real estate developer, and one of you is the president of the neighborhood association. So go ahead and read through your intros. No, you're reading it in your mind. So you have different sheets so you can better understand who you are. And the first phase of this negotiation is to negotiate this donation. So we want you to negotiate with the person with you. You actually need to come up with a number, and we will share and compare those at the end. All right, you should have finished reading about now, and you'll have 5 minutes to negotiate with your partner. And again, come up with a number. We need a number for this donation so we can move forward with the development. All right, I hear some successful negotiations. Has everyone come to a number? If you haven't, you got about 60 seconds to nail down your number. All right, so how did we do on our numbers? Anyone want to shout out? How much are we donating? Developer? 25. All right. 30. Numbers in the back. How much did we donate? 35. 50. Whoa, man, look at that generosity. Okay, so listen to that swing. And so a lot of where you ended up probably depends on what you were able to find out about the other person. Who found out about the blight in the sycamore trees? Right, so you think the sycamores are really precious, and there's no way they'd ever want to cut them down, but actually they're diseased. They have to come out anyways. Right, so getting to something that's behind why something's happening can help you negotiate, rather than thinking this is something precious. The community is going to be so sad to lose these trees. They've got to get those trees out anyways. They'd have to pay to cut them down anyways. And so sometimes getting to those underlying interests can help you negotiate from a different standpoint when you know what the other person, you have a better understanding of what their position is. So as we go through the talk, we'll kind of reference this idea of getting to a number and help you think about how you can more successfully negotiate either a lower or a much higher donation. So we're going to start with the first part about preparation. Now, you've all shown up here today. You didn't even know you'd have to talk during this workshop. Sorry about that. So you really didn't have any time to prepare. So we're going to go over 5 steps that you need to do to prepare for any negotiation. We'll do one more little negotiation, and then we'll talk about kind of these common questions that come up.
Great. So step 1 in this 5-step process that we're going to talk about is really figuring out what you want. And we put this in context of a lot of career change, because we figure most of us are coming in here thinking about not negotiating with a developer, but more negotiating at work for a step up in your roles. And so a big piece of this is really figuring out what you truly want. And spending some time doing some reflection. I think a lot of us kind of get in the rat race of, just what's the next step? I'm going to kind of follow in the footsteps of everyone else and go through these paths, and really giving some solid time to thinking about what really makes you happy, what fits with your life, and what your real goals are, not only, tomorrow or next month, but also in the next few years. And some of that has to do with who you surround yourselves with, who you talk with, what kind of education you get about all of your options. And so I think it's an important piece here to kind of mention that you really need a mentor and a sponsor, if not multiple of those. And they're 2 very different concepts. So the mentor is someone who's been through what you've been through before, kind of understands your plight and whatever is on your mind at the time, and can help give you some guidance, more from personal experience, some more personal interaction. Sponsors are folks who are a little bit perhaps higher up in a role in the organizational structure, maybe are not quite as close and personal with you about talking about these day-to-day issues, but really have a network that you could benefit from. So they're the ones getting the emails in their inbox every day about opportunities. And if, these are like the chair of your department or folks in the C-suite, if you have a sponsor who knows what your interests are and your goals are and is looking out for you and can connect you with those opportunities, you're gonna have more success in getting to those goals faster. So you really need both of those. And then lastly, coaching. Professional coaching can be pricey. There's a great way to kind of shop for coaches online with this there's an International Federation of Coaching. It's a very reputable site. But this may be something that you use particularly when you're at a crossroads in your career where you're making a big jump from one step to another, from one geographic area to another, and you're really having to kind of organize your thoughts and goals in a very intense and serious way. That's when the coach can be super helpful if you're going to have to figure out when to invest in that in your career.
So the next step is to think about what you need to learn beforehand. Now, you didn't really have an opportunity to learn about this playground. I tried to give you a couple of anchors so that you can understand some general cost, but we have the benefit, if you're doing a real negotiation, that you can really get a lot of this homework done before you get started. You've got to get objective data. So if you're negotiating a salary, you've got to get the AAMC data, the MGMA data, to understand what are those percentile brackets so that you can start negotiating in the right place. The more you know about the landscape going in, the better you'll know what to ask for. The worst case scenario is going into one of these negotiations not knowing even the range of what they're planning to offer. That's how you end up with a agreement that isn't quite beneficial if you have no idea what the range is, right? When you are the developer, right, you're willing to pay up to $50,000. That doesn't seem like that much. You're about to make millions. Whereas you're the neighborhood president, you'd be grateful for anything. You'd be grateful for 10, 20, 50, 25,000. And so depending on who has the data and who's willing to say that number first is going to depend a lot about, or is going to determine a lot about where you end up there. So get that objective data as you move forward. So it's not just data. There are other things that will determine who has the upper hand in a negotiation. So information here, that's that second horseman. This is a great paper out of the business literature. And so information is only a part of that. Having alternatives is really an important part. So knowing what your alternatives and having explored those alternatives, but also exploring the alternatives of your partner that you're negotiating with, knowing what they can exit to, right? If you don't come to some type of agreement, what will be their plan B, and then knowing what your plan B is as well. And then the other two horsemen, just knowing, who has the general upper hand as far as status and social capital, who you know, and kind of what position you occupy within the organization.
All right, so the next step is defining your strategy. And this is the part that I think just takes a lot of thought. When you're going into a negotiation, you need to kind of set your target value and your reservation value. Your target value is like the pie in the sky aspirational goals that you have, and it could be multifactorial, right? It could be not just how much money you're going to make per year, but it could be the resources that you get in the job, or where your office is, or whatever things are important to you. But you have some sort of combination of the pie in the sky, and that's the target that you're going for. And then you can see in the middle there's a reservation value. The reservation value is the lowest that you're willing to accept before you go down a different avenue with Plan B. And the reservation value is really important because if you don't set what the lowest combination of factors is that you're willing to accept, you're going to go even lower, right? And so you got to kind of set your boundaries before you go into the conversation. And then the last piece is something called the BATNA. And the BATNA stands for Best Alternative to a Negotiated Agreement. And it turns out that if you have a better BATNA, you're going to have more success in your negotiation. So think about this. If you're, like, hypothetically speaking, if you're a program director and you really want to, you think it might be fun to live in Boston and you're living in Alabama, and but you're really happy with your job and you've got a great work family and you have all the pieces and parts that you need and you're pretty happy, but you've always just really wanted to live up there, and maybe the salary is like $10,000 more, and you want to. You might get an extra APD and a few extra resources. If you go into that negotiation and you're really happy with whatever your BATNA is, staying back in Alabama and doing your original job, if you're comfortable with that, you're going to go into the negotiation with more confidence because you don't feel as nervous about, oh, what am I going to lose? And I've really got to get this opportunity. And so spend some time thinking about what is my best alternative. And the stronger you can make that best alternative, the better your negotiation is going to be. And here's kind of a framework to think about it. So you really want to think about the BATNA as like the complete opposite fork in the road. So this is like you walk away and you're going to go with a completely different plan.
All right, so let's talk for just a second about anxiety. When you start thinking about negotiating, I know a lot of people get that feeling in their stomach. You start to get nervous. You're going to have to go in, talk to your boss, and ask for something. So what do we do about that anxiety? Well, what we know doesn't work is just to tell people just to calm down. Have you ever tried to do that when you feel real nervous? Just calm down. Just take a deep breath. Everything's going to be okay. So instead of doing that, what I'd like to suggest is something from the psychology literature. So instead of trying to tamp down this high arousal state that you have, it's really hard to do that and tell your body not to be in this state, but you actually can reinterpret that anxiety as excitement. This is not just a mind trick. This really works. It's been proven to work with things like public speaking, singing, test taking, that you can't get rid of that energy that you feel, so you may as well generate it or push it towards something else, and excitement is that thing that you want to push towards. So you see this as an opportunity, not as something that you have to do, an opportunity to improve whatever position or status, whatever that you're doing. The other thing that's great about this is it's not something that your body gets used to. You're not going to develop a tolerance to this. You actually just get better at it the more you practice. So the more often you use this trick, the more often you'll be able to, in other cases, reinterpret what you're feeling on a shift, have something you're feeling anxious as excitement opportunity. So I think that that's a neat thing. This is not a way to trick yourself. It's a way to use your body's own feelings and just change the way you perceive them into a different way. Another thing that will help with anxiety is to go ahead and imagine the worst alternative to a negotiated agreement. So as Dr. McCoy said, your best alternative is what's the best case scenario if you can't come to an agreement with this person. But go ahead and imagine the worst thing that can happen, because when you get to the negotiating room, that thing might be in the back of your mind. So beforehand, before you get there, go all the way down the rabbit hole. Just chase that rabbit as far as it goes. And usually when you get to the bottom of the rabbit hole, you'll see you're still alive, everything's still okay, like things are gonna be all right. And so if you've already imagined the worst that can happen beforehand, it's going to give you a lot more confidence when you get into the room, because you don't hold that anxiety. You've already explored it, and even if that option happens, things will be okay. And then the final thing is to address our imposter syndrome. It talks on this at CORD and SAM every year. Imposter syndrome is what it is. We all feel this to some degree. So what I'd encourage you to do is think of one of the most famous imposters that ever lived. That was Superman. So get your Superman clothes on, your earrings on, call someone who really loves you, who can help pump you up before you go in there, and approach this from a place of confidence. If you're coming in with data, knowing what's important to you and knowing what is possible, what is reasonable to ask for, that's going to give you a lot of confidence going in and dispel a lot of the anxiety that you feel.
All right, and the last piece of this portion of the talk is really talking about setting up for success. So there are actual entire books written on timing and place and your focus, right? And so these are really important things to think about. So put yourself in the shoes of the person or people with whom you're negotiating, and think about when you're approaching them and how it would feel from their perspective. So in other words, if you're asking your chair for an extra 20 grand to do some project, picking 8 a.m. on a Monday morning is probably not the best time to make the appointment to meet with the chair, right? You got to think about, they're coming in, they've got like 100 emails in their inbox already, people are calling them, things are happening, and so they don't have that same relaxed, jovial approach typically at that time of day. The more you know about the people with whom you're negotiating, the better, because some people are more morning people, some people are more afternoon people, some people do a lot better right after they've eaten. So there's a lot of data to say, don't go in early in the week, go in a little later in the week, maybe right after lunchtime. Not so late, not Friday at 4:30 where their mind is already, at dinner, but maybe Friday at 1. And so there's actually some strategy to this. The other piece is your timing and what you're doing before you go in. So you're never as effective if you have been in a traffic jam, you're running late, you're sweating, you're already stressed out, and then you're coming in to have this conversation. So you need to be a little selfish and do whatever you need to do to get your mind right before you're having these serious conversations and high stakes conversations. If that means going to yoga, going to run, whatever it may be, do whatever it is, be super early, be relaxed when you're going into the conversation. And then the last piece is the exit. So remember, you don't have to finish the negotiation in that one setting. So if things aren't going the way you had planned in your mind, and you're really not getting to any endpoint that makes any sense to you, you can always say, hey, I got a lot to think about. Maybe if we could just take a couple of days, maybe regroup on Monday, or maybe not Monday, right? Wednesday of next week, and talk this through and kind of come to a resolution that'll give me some time to get my thoughts together. That's okay. It's okay to leave the negotiation without the actual plan executed. So that's the last piece. Just think about the timing of this. So now we're going to have you've got your second sheet. We're going to give you a minute or two to kind of read through the second piece and then negotiate the final portion of the scenario. It's just kind of a continuation of the initial.
All right, we're looking for a vision here. So at the end, we'll kind of share what type of agreements you guys came to. All right, one more minute to wrap up. All right. Lots of good discussions going on out there. Has anyone reached any type of vision of what this might look like that they'd like to share? All right, let's hear the vision. Perfect. Oh, I love it. And walking trails. Oh, awesome. Okay, but all single-family homes. Okay, all right. What did you guys end up with? Oh, still negotiating, driving a hard bargain. Not agreeing so quickly this time, huh? What? Yeah. Mm-hmm. Mm-hmm. That's fair. Yeah. All right. Any visions from the back? Okay. Yep. Take a pause. Yep. Great. All right. What about you guys?
We're happy with single-family homes. We're trying to discuss whether there could be another phase.
Ah, yes.
Those extra ones that they wanted somewhere else.
Right, so that this goes well, there's potential for things in the future. All right, so hopefully we've touched on a lot of the issues around negotiation. In the next section, we're going to go through the 5 most common conundrums that kind of come up when you talk about negotiation, when people ask questions about what they should actually be doing. So this is the practical portion, like what you should actually be saying and doing when you go into a negotiation. So one of the things about negotiation is that when you ask people how things went, that when people perceive the success of the negotiation, it's based more about how they feel about the negotiation than always the exact number or agreement that's come to. So psychology here is just as important as business, and that's why a lot of what we're going to present actually comes from the psychology literature. Because if people feel better about the way that the negotiation went, they're actually more likely to accept a lower number or value than maybe they even originally intended. So it's not manipulation, it's helping the person that you're negotiating with feel good about the outcome that you come to. So first is, what do I actually say? I'm going to have to sit down with my chair, my boss, my somebody, and what am I going to say to open things up? So the first thing I'll say is, don't say anything, just start asking questions. Okay, so why are we asking these questions? It's because we're trying to get to what is under your position. So usually you come into a negotiation, someone's at point A, someone's at point B, and those are your positions that you hold. This is what I have to have or have to come to. But that's not the whole story. We know that there's a lot below that, and what's below that are the interests. And the only way to get at the interest are to ask questions. So just like in the beginning part when you're talking about the trees, like how do they feel about the trees, the health of the trees, how long they've been there, what is the plans for the community regarding the trees. If you've got to get underneath just the playground to the interest at hand to realize actually both of you want the same thing. Both of you want the trees out, rather than it being, I want the trees out, I don't want the trees out. Everybody wants the trees removed. So if you can get down to the why, that is the most important part, and that's why you ask questions. You always start a negotiation with a question. So the other thing is using questions to help develop what we call tactical empathy. Okay, so the more you understand about the person sitting across the table from you, the better you can truly help come to an agreement that benefits both parties. Okay, so these are ways to employ tactical empathy by asking questions, by actively listening, by repeating back to people what you hear them saying. So if someone, says, well, I can't do that because budgets are tight. You start your next sentence with, budgets are tight. That's why I'm making a few proposals that will help not only, save on the bottom line, but also bring value to our department. So you mirror what the person has said using the last few words of their previous sentence to help start your next sentence. That helps show that you're actively listening to them and that you can build upon that you guys are actually coming at this from the same team rather than being opponents. And then finally, using calibrated questions. So you want them to go ahead and imagine you in the position. So if you're applying for program director, what would it take for me to be successful in my first year as a program director, right? You're already putting yourself in that position. During my first year as chair, what would be the major goals that you'd like for me to accomplish, so that they're already thinking about you in that position. So it's asking questions, but asking questions in a way that calibrates the conversation in the direction that you want it to go, already assuming that you're going to be in this position, that you're going to be taking this leadership role, and then imagining what it's like from there. So don't say anything, just ask questions to start. All right, the other thing is you actually don't have to say anything sometimes. If you are negotiating with someone and you are just willing to pause, I'm sure you've seen this happen before. Someone makes a statement, there's a pause. The person might actually start to make a rebuttal to their own statement that they just made, because people hate having empty space there. And so they will fill it with anything. They'll start, well, you might think that this, they'll come back even contradicting what they just said if you're just willing to pause. And sometimes the person who wins is who's willing to pause the longest. So be comfortable with the pause, be comfortable with time, and let the other person do more of the talking. You be the question person and you be the patient person, and let that other person kind of talk through it in their head. All right, so what if they ask you a difficult question, right? Everyone reads the same books, so you're asking them questions, they're asking you questions, nobody wants to answer anything. So what are you gonna do when they ask you difficult questions? So one of the famous quotes from negotiating is, the most dangerous word in business to say is no. And the second most dangerous is yes. But it's possible to negotiate without ever saying either. Yeah, this is what always frustrates me when I talk with a business person, right? It's always, it depends, or we'll see. And so you can play that game as well. So if people are asking you questions that are difficult to answer or that aren't beneficial for you to answer, you've got to reframe the question. So don't be tricked into an ultimatum or a this or that. There's always another answer rather than yes or no or A or B. So help to reframe whatever question that they ask you, right? Is it A or B? I can't see A or B either making both of us happy. Let's think about C, another way to imagine this problem, right? So you can reframe anything that they give you, and it's really important to do that and not fall into the trap that someone sets for asking you one specific question. All right, if there's an underlying concern, there's some type of elephant in the room, go ahead and address it. If you know that, they're going to ask you a question about X and you're nervous, maybe something, a project that you did that never came to completion, right? And you know that that's in the back of their mind. They know about that. Go ahead and address it. If there's going to be an elephant in the room, they're going to ask you a difficult question. It's okay to come bring that to the forefront, address whatever's there to make sure that you can, make sure there's no lingering things in their mind to say that you don't deserve this position or you don't deserve the raise or whatever it is that you're asking for. And then finally, reference your objective data. You've all done your homework because you knew how to prepare, and go back to that objective data over and over and over again. It's very easy to argue about feelings, conceptions, visions, but objective data is data. And so if you have a way to come back to something that is concrete, something that is able to be looked up, checked, that is something that is factual, it's nice to be able to come back to that with these questions rather than having to negotiate around thoughts or feelings. All right, this is my favorite part, is getting to the number, right? Who says the number? How do you get to the number? So when you guys were negotiating earlier for your playground amount, how should you have approached this? Well, there's two schools of thought, okay? The first school of thought is what everyone's always been taught. It's that you make them say the number first. Definitely they should say the number. This is what is conventional. And in an unknown landscape where you have no idea how much playgrounds cost, it's a fine strategy because you have no idea if they're going to be willing to pay $10,000 or $50,000 or maybe even $100,000, right? So let them say the number first because maybe they're considering, like in this case, they're considering like $50,000 to $80,000. They'd be willing to pay that much, right? So let them say that number first, and on the inside you might be like, wow, they started with 45? That's twice as much as I ever thought that I would get, right? But then you know where they're negotiating from, so you can see their cards once they tell you that initial number. So that's why that wisdom's there. And sure, if you don't know anything about what you're doing, that is the way to go. However, what I'd like to say is that for most of us who do have a known landscape for things like salary, et cetera, that actually saying the number first is more beneficial, okay? So if you know the landscape, you can use anchoring bias to help you. So let's talk about anchoring bias, and then we'll talk about the benefits of each of these. So this was the first paper on anchoring bias from the mid-'70s in psychology literature. So they got random people, they asked them a question. What % of African countries are in the UN? Okay, and then they had a roulette wheel there. The person spun the roulette wheel, and it was set to either stop at 10 or 65. And so they asked the person, okay, that's a hard question. So is it higher or lower than 10? Is it higher or lower than 65? So they'd say higher or lower. And then they asked the person to give a number estimate. For the person or the people whose roulette wheel had stopped on 10, the median estimate was 25. And if your roulette wheel had stopped on 65, your median estimate was 45, right? There's no reason, who actually knows the % of African countries in the UN? I don't. But that wasn't the point of this. The point was that once you're anchored at a number, you're more likely to guess closer to that number. And the same thing happens in a negotiation. Another one of my favorite anchoring bias examples was this one. What are the last 2 digits of your social security number? Right, you say those. Then they bring out a bottle of wine. How much would you pay for this bottle? Right, just a bottle, nothing special. And you can see that the lower that number was of your social security number, right, something random that has nothing to do with wine, still affected the average that people would estimate that they would pay for this random bottle out there. That's how our brains work, right? Once you get anchored on something, it's really, really hard to get away. And that's why this is helpful in a known landscape, because you have the ability to place the anchor. The higher, if you're talking about salaries, the higher the first number that's thrown out, the higher that initial anchor is, the higher the negotiated agreement will be. That has been proven time and time again. So don't be afraid to ask for those numbers, because the higher you anchor, the better outcome you're going to end up with. So what do you do if the other side anchors? What if you get anchored, right? They throw out something that is just, completely too low. So we'll do, random salaries. You're applying for some job and you think you should probably make, somewhere like 180, right? And they throw out 110, okay? The most important thing is not to fall for the anchor. You should never counter an anchor. So you should never say, okay, they said 110, I'll say 160, right? Or even 170. You've got to diffuse the anchor completely, right? So saying things like, I hear that 110 is a fair price that you think should be paid for this. However, we are miles apart here. And unless we can start this negotiation between 200 and 300, I'm not sure we can move forward, right? So you've got to recognize the anchor and not fall for it. Never counter offer on an anchor that's out of your range. Completely diffuse it and restart the negotiation. When you do restart the negotiation, use data to back it up, right? Because you don't want to seem like you're unwilling to negotiate, right? We're miles apart because 200 to 300 is actually, the median quartile for someone with my level of experience for this type of position. That's according to MGMA data, right? So you've just referenced something that is objective that they could look up, and you completely move the anchor to another range. So what are the difference in these two things? It is whether or not you know the landscape. And that's why the homework piece is so important, because the more you know, the better you'll be able to negotiate going in. So if you don't know the landscape, you have no way to figure this out, sure, let them say a number. And actually, when they do studies on this, having the other person say the number makes people more satisfied with the negotiation because they have less anxiety about it. It's easier not to be that first person, right? Saying the first number is anxiety inducing. So sure, if you want a happy, comfortable negotiating experience, fine, let them say the other number. But if the economic outcome is what you care about, you've got to be brave. You have to be the one to do the anchoring. All right, so what number do I say? So this is certainly extremely specific to what you're doing. So it's really important to talk to a mentor before you go through this. First, give a range when it's appropriate. When you're talking about your MGMA data, give them the median quartile, give them the 50th to 75th percentile range, right? Give them some range, because we all know that's never about one single number. It's about lots of other things that go into it as well, other benefits and things that you want, things that are important to you. So give that range to allow for some flexibility back and forth. Next is, if you can be precise about a number, that helps with your negotiation. So when you talk about anchoring, you want to anchor in the type of, in the range, but you also want to anchor in the scale. So if you're going to pawn a ring and you're going to go in and you really want, $700 for it, right? Going in and saying, how about, $720, they're going to be more likely to negotiate in smaller increments than if you go in and say $700, then they're going to be more likely to negotiate in the hundreds, so to come back and say $500. Whereas if you give a number that's in the tens, like $720 or $724, they're going to be more likely to negotiate in the tens place rather than the hundreds place, and that's been shown over and over again in the literature. So if you have the ability to be that precise, if it's something that you're negotiating, that's always better as well. And then finally, stop apologizing. I think we say this all the time. I'm sorry, but I just can't take less than 200. I'm sorry, but don't apologize. Just justify. You're not sorry. That's what you deserve, and that's what you're asking for. So don't apologize for it. Just justify it with numbers. All right, next. A lot of people don't like to negotiate because they're afraid of the relationship, right? I don't want to make someone mad. I have to work with this person forever. So absolutely, proceed graciously. Be a kind negotiator. Especially if you're going to need to do more deals or negotiate with this person in the future, right? You're going to work with someone for years to come. It's best to be generous as you go. You don't always have to get everything out of every single negotiation because there's likely to be more in the future. And one of my favorite quotes, if you're going to skin a cat, don't keep it as a house cat, right? So if they're really, looking to get every single bit that you can, you might make enemies. And so generosity really does have its place in negotiation as well. If you're going to have to tell someone that they're definitely not getting something, and it's going to be multiple things, do it all at the same time. So satisfaction with the negotiation decreases when people have multiple losses that are spread out. So if you're going to have to do something like rip the Band-Aid off, go ahead and tell them all 3 things they can't have right at once. But if you know you're going to be able to be generous and give things to people in the negotiation, spread them out. Because every time you give something, the person feels inside that they've won. Okay, so let them win over and over again. Because again, it's about satisfaction with the negotiation as much as the agreement that you get to. All right, and finally, delaying acceptance. So if you go in and someone says, well, I'll give you $30,000, you're like, okay, that sounds great. Then the person that said 30 is like, was that too much? Should I have said less? Right, so if you agree right away to something, it makes the other person less satisfied with the negotiation because they feel like they could have gotten more. So even if you know you're going to stay around that amount, there is some benefit to saying, well, let's talk a little bit more, and delaying that acceptance, because that will actually increase the satisfaction of the other person that you are negotiating with. And then finally, there's a fine line between gloating and celebrating. So do your celebrations in private. No gloating about how well you did, especially in front of that person. And finally, this is a lot of what Dr. McCoy talked about, was pressure tactics. People will always try to get you to come to an agreement in that initial negotiation. It's better for them if you go ahead and say yes or no, or are pressured into taking something, rather than realizing, well, that's not as good as my botna, so I should probably walk away from this. So have a way to slow down, have a specific exit strategy that Dr. Nicole mentioned before, so some type of pause with the knowledge of when you're going to come back to something. And then finally, don't be tricked into closing the deal, right? That phrase is in our society and our culture, got to close the deal, got to seal the deal. Sealing the deal sometimes is not what you want to do. Once you get to what the deal is going to be, if that is not as good as your BATNA, you've got to walk away. And sometimes walking away actually means winning, okay? So don't get bullied into finishing something. It's okay to take a break and move forward. All right, that is it. Those are the 5 most common things that people ask us about, and we'll take questions.
One thing my boss used to tell me about, I didn't have the answer to them. I knew that, I basically knew you need to do your homework, know what the standard is, what people, this was I was negotiating for. It wasn't money as much, but it was hospital sites and opportunities, that I knew other people were getting. And his response to me was, I don't want to talk about other people, let's just focus on what you. And it was very frustrating, because it was like, I was clearly saying, I know this is possible. I know other physicians in our department have been able to manage X, Y, and Z, or have had this opportunity and worked with this, and it was like, don't want to talk about other people, I want to talk about you. And that was just like a non-starter for me, and I had this visceral reaction. And then, can you give me a good response for that?
Yeah, I think that, so he's reframing. So he's doing exactly what we tell people to do, right? So reframe that question instead of responding to this, completely turning around, don't compare apples to apples. This is a different situation, it sounds like, is what he was saying to you. Yeah, I think that when people come in with things like that, I think you agree, that's fine. Let's do focus on me. So when I look at my goals, whatever reason you're trying to work at these other sites, here are my ultimate goals, and here's what I'm trying to get to, which is why working at these sites is going to increase my academic portfolio, or whatever you're trying to argue for. So I think it's fine if someone has said we're not going to use that objective data, right, and they've taken that off the table. I don't think you can force them to do it. But what you can do is say, okay, I can't use that pathway. I've got to turn and find a different pathway. So I'd find whatever other reason that you have. Sure, I see your boss's point, comparing you to other people, right? Everyone's a different employee. But for you, why is this important? For you, why is it going to make a difference? And so if he wants to bring it back to you, fine, bring it back to you, and find ways to argue for what you're going for based on your goals.
In the same vein, you can also use the technique of saying, how do you see me in whatever role you're going for, in that role? Start your sentence with, when I'm working at blank, or as we move forward with our conversation, if you see me working at blank, how do you see me in this role? So that he's already thinking about you in a context of this role and this job. So if he wants to focus on you all day long. How do you see me in this role? How do you see this working out? And really, totally steer the conversation in a different direction. And sometimes I think that those the chair, whoever this is you're negotiating with, they may feel nervous talking about other people's data. And so I think the other thing is, sure, he may have been using this as a reframing tactic, but also kind of giving the benefit of the doubt of maybe he feels uncomfortable talking about the other people's data. So let's look at other data we have that's a more general group of data about how this works at other institutions. Or, you can also kind of reframe it that way and counter what he's saying. So.
All right, thank you guys for coming.
These are little worksheets to help you kind of think through your negotiations ahead of time. So we'll give them to you on the way out.
I'm so glad you didn't start
Who's now going to be forced to participate? Should we give a few minutes, or we just and we give it till 5 after? Yeah. Yes, exactly. I know, I did not intentionally do that, but I'll just kind of blend in now. Yeah. Uh-huh. Yeah. Yeah. Guest of honor. Sorry, it's a packed house, so. Let me give it one more minute, and then I apologize to the 3 participants who are now going to have to participate. Yes. Get started? All right. Well, hello everyone. I'm Jason Lewis. I'm from Beth Israel Deaconess Medical Center in Boston. Together with Dr. Thomas, Dr. Evans, and Dr. Gittens, we're going to be speaking about administrative hygiene, what it is, and how to address it. The agenda for today, we're going to briefly discuss some background on administrative hygiene, professionalism in undergraduate and graduate medical education. We're then going to have 5 distinct cases addressing different issues of administrative hygiene and break out into smaller groups, although in this case we'll just be one group, to discuss strategies and experiences you may have had and kind of come back together to further discuss those strategies. So I'm happy you may all have your participation hats on. We'll then have some time at the end of the talk for just some more open discussion on any other experiences you might have had or experiences or strategies you've used in the past. None of the 4 of us have any conflicts of interest to disclose, so at this point I'm going to turn it over to Dr. Thomas for some more background information.
Okay. Pardon me as I try and navigate technology, which is always a challenge for me. But so is this working? I don't know if this is working. If it's not working, it's fine. I'll yell until we get it figured out. So one of the reasons that we wanted to talk about this is that, like, oftentimes many of us will have heard our sort of interns, our residents, people talk about, I just want to be a good doctor, saying that, in order to be a good doctor, in order to do my job well and to take care of patients well, in order to be a good doctor, I just need to come in, do good clinical care, and then leave. And then that seems to be the overarching sort of view of what we do as doctors. And so in that definition, actually, we all know that we wear a variety of hats in our everyday job, even if we're just community physicians and we have a full-time FTE clinically. We actually are not only physicians and clinicians providing clinical care, we're also subject matter experts. We end up doing a lot of teaching, sometimes just of our patients, sometimes of residents, PAs, advanced practice providers, medical students, et cetera. And then many of us also will have an additional hat, something like research, something like education, ultrasound, sonogames is going on right now. But also, in this day and age, I was expecting maybe 2 more people to show up, but someone to challenge me on this statement that none of us are self-employed anymore. As emergency physicians, we do not work for ourselves. We work for someone else, whether that's a democratic group, whether that's another group that's run by a hospital, maybe it's a university. We always are employees of someone else. So all of us have administrative requirements that come with our jobs. Residents oftentimes like to think when we are in residency, like, all of these things will go away after I graduate and I'll just be able to do medicine and everything will be wonderful. Sorry. A lot of the things that we do in residency also kind of have direct corollaries in our employment. So things like duty hours submission can sort of closely correlate, sorry, clinical correlation, doctor, with timesheet submission, reporting moonlighting hours, procedure logs, and then CME and maintenance of certification. And you always have to attend something, right? Whether it's a staff meeting, whether it's didactics, there is a minimum requirement usually for attendance at some specific thing. So we're using this sort of branch term of administrative hygiene in the sense to say that there are certain things that you need to do in order to be palatable to other people. So there's kind of 3 buckets that these fall into. One of them is accomplishing required tasks. You have to do X by a certain date in order to accomplish this task. Another one is time-sensitive communication. This is kind of the stereotypical, you have to respond to emails within 24 to 48 hours. You have to kind of respond to people in a timely manner based on the urgency of their communication. And then there's this sort of larger bucket that's a little bit more difficult to define, but has to do with organizing yourself and your time to make sure that you are showing up for things that you need to show up for, and that you are managing your time appropriately to make sure that you can accomplish all the things that you need to accomplish. So, why do we care, right? Like, what's the big deal? Who cares if we get all of our stuff done? You know, who cares if we're really good employees? 2 different reasons. One is that increasingly over the last, I was going to say 10, but I'm realizing more and more how old I am. Over the last probably 20 years, employers and residency directors, fellowship directors, everybody down the line is now asking previous medical schools, residency directors, et cetera, how does this person do administratively? Are they going to be a problem person for me? I can hire a lot of good doctors that can, that can do a lot of really good clinical care, but am I going to have to chase this person around in order to maintain their certification and turn in their licensure requirements, et cetera, et cetera? So why else do we care, other than being employable? It turns out that most of the issues that come up that really affect employability down the line, state licensure board censures, imprisonment, lawsuits, this all has to do highly with professionalism. So we read through all these things so that you don't have to. Some of them are a little bit dry, but the kind of seminal article in this field is by Papadakis, and that's kind of on that left-hand side of the screen. And really what it says is that they did this huge case control study where they looked at all of the graduates of these 3 medical schools across 3 different states over the last 20 years. And they said, how many of these people ended up being brought in front of their state boards for some sort of reprimand, right? And 94% of all of the physicians that came in front of the state boards for some sort of reprimand were for professionalism issues. They were not for necessarily clinical incompetence. They were not necessarily for, I made a big boo-boo during clinical practice and this has come back to bite me. It was usually somewhere in the realm of professionalism. Now, what do we mean by professionalism? If they break down a lot of these professional behaviors that people were brought in for, it turns out that the odds ratios of things like severe irresponsibility, if that is seen during your medical school career, the odds ratio on that is 8.6. You're 8.6 times more likely if you've been brought into a professional review board to have demonstrated irresponsibility during your medical school years. And then you see other things during residency. Residents who had been censured or had been brought in front of some kind of professional review board during their medical school careers were more likely to incur problems in residency, and were actually twice as likely to be sued afterwards in clinical practice. And this really, a lot of this has to do with irresponsibility oftentimes, those things like didn't show up, reliably to clinical practice, consistently late, didn't turn things in. It's just this kind of basic administrative hygiene that like any of us can do. It's just annoying, but we just have to do it. But those things, if they continue on to kind of snowball throughout people's careers, are the things that bring them in front of medical boards. It's not necessarily you're bad doctors and you don't know how to practice. It's you don't know how to manage yourself and your time. So with that, there's been a little bit of talk in the bottom left. Prasad was one of the people who looked at these things and said, well, we have to be really careful how we use this data, right? Like you can't just say that anybody who's ever been brought up for any kind of professionalism issue in medical school now needs a remediation plan for the rest of their lives, because the incidence of people actually being censured for professionalism things is quite small. 0.3 to 1% of practicing physicians will ever be brought in front of a medical board for any kind of censure or disciplinary reason. So the pretest probability of these things is very, very small. So we can't necessarily say everybody who ever has a professionalism issue during medical school needs to be like blatantly restricted from practice later on. But there are things that we notice during training that we need to target, and we need to take them seriously when we do see them. So we're going to now break up into our group. Thanks, Sono Games. We're going to break up into our groups. We can pick the topics. We have a couple of cases to go through. We can pick the topics that we're going to talk about for each case, discuss it, how we might address these things in practice when we see them in our trainees, and then just kind of come back as our group, our larger group, and discuss them a little bit. So feel free to share your worst, weirdest, and most wonderful instances of some of these things and how you've addressed them either effectively or very ineffectively in the past, because all of us have been there. Right. Yeah, it's fine.
Can they see me? Hi, everybody. I'm Aisha. Oh boy. I'm a third-year resident at the University of Connecticut and also one of the chief residents. And the first case we're going to be discussing is around schedule requests. We initially broke this down into undergrad and postgraduate medical education. So the first case is approaching a clerkship, a student submits excessive and unreasonable schedule requests ahead of time, essentially dictating a schedule with unrealistic expectations. How do you approach this situation? How do you address this as a student's mentor? On the graduate medical education side, a particular resident perpetually does not submit any schedule requests by the deadline, and then last minute bombards the chiefs, admin, and schedulers to swap shifts due to scheduling conflicts. Who is the best person to have this discussion? And again, how do you approach this? And now we'll open to discussion within the group. About have you had this situation and how did you approach it, and what was your takeaway from those experiences? Have you guys ever encountered this challenge?
Not yet. But I know that I will. Just from the chief resident forum, I think there was a big emphasis on being sure that you're peer-to-peer with people and figuring out what's the source of you not submitting scheduling requests by the deadline. What's going on in your life? Do you need more reminders about the schedule? It puts a little bit more stress on all of us, and kind of just leveling with the person and having a one-to-one conversation and not all the chiefs with this one person. And yeah, I guess finding the source of why this person is behaving this way is the most important part, I think.
Thank you. Over the last 1 year of experience, I have definitely learned that as well. We have another offer.
Yeah, so I think whenever you look at these types of things, it's kind of balancing individual versus systems issues, right? You can't be a little bit you can't be fully functional if you're not a little bit like internally introspective as to why these things are happening, right? So like a lot of things can happen that are completely independent of systems and needs to be addressed on like an individual level. I look at the left-hand side, and I see like excessive and unreasonable schedule requests. So it's like to understand if it's excessive and unreasonable, what is the reasonable and non-excessive baseline for that, and is that defined to your students and your learners first, right? So it's like, if there's no guideline for what your requests are, how many days can you request off, how many weekends can you request off, can you not request off 48 hours in a row, like those types of things, like you can't always assume that they're making something unreasonable if they don't know what the expectations necessarily are. And I think a lot of the things that we do as like educators and in supervisory roles are like, we just assume that people know. And if they do know and they do get those like, these guidelines are like, you have a paper or like a, like, what do you want to say it? Like a survival guide or whatever it is that basically like has these sets of information, then you could be like, okay, like just making sure you see this, you're aware of this, this is the expectation and this is like the guideline. Not to say we all need to like fall back on policy, but having that to like back up as like a basic standard of kind of care or, standard of practice or expectation is important, because that you also then have some like hard information to go back on and be like, well, this is the expectation, this is where it states that this is the expectation. Hopefully we can do that further. What are the barriers then to this, and talk about it in a more personal, like holistic, supportive fashion.
Thank you. Any other discussion points? Thank you, Lauren.
So I completely agree. As previous clerkship director, it was amazing how many students maybe didn't realize that how this comes across. And a lot of these students have never really had a professional job at this point. And so I think we found that a little bit of that sitting down and having this professionalism talk, and this was turned into part of our orientation of a little bit about the professional expectations for the rotation and for the student. And I think overall it helped them for our rotation, but hopefully maybe impacted them for future rotations, so that we don't see this several rotations in a row. And I think that when you are the mentor and this is something that's occurring, it's really important to sit them down and make sure that they realize these expectations. I mean, it absolutely does. And so a little bit of it comes down to kind of why these, again, why are these requests occurring? I think that at some point you do have to limit it, again, for the systems issue of you can't have certain students dictating the full schedule of maybe we find in emergency medicine, maybe certain residents want only a day shift, but then some of our other students don't get to experience what a day is like in the emergency department compared to a mid or an overnight, which does have different a different feel. As a nocturnist, I can say a different feel than the other shifts. So I think it plays a part, but unfortunately it can't always completely still dictate the schedule from that standpoint.
What do you do when you have a repeat offender? So you've had this conversation as a peer, as a chief, as faculty, as a mentor, but yet every time, fourth time in a row, fourth block in a row, you're having the same issue. Then what?
I feel like if it's a conversation that's happening multiple times and I've tried to address it with just you, maybe you need to hear something from somebody else, like a person of power, perhaps an APD or a PD. It will get through to the person and they'll realize that there are actual repercussions to unprofessional behavior.
As the person in charge of reviewing the faculty schedule, this still comes up. I think you have to be honest with them about the burden that they're putting on their peers, but
it's also a good chance to reach out to the entire group and kind of address this issue as a whole. It may be that one particular time is more stressful, and that's why they're asking this for 3, 4, 5 months. Normally they wouldn't, and if you can get to the bottom of that directly talking to them, that's fine. If they can understand that it's really impacting everyone else's schedule by addressing it as a whole group, I think it can also be impactful.
Thank you. All right, well, do we have another point? Oh, I'm sorry.
That's okay. This might be taking it a little bit different, but I also think that like while face-to-face conversations are like very valuable, when you look at things that are especially like repeat instances, having some sort of paper trail for it is just as important. So like if it's a personal conversation, giving a summary to like if you're a chief resident or if you're an APD, like writing down the details of the conversation, summarizing it, giving it to your program director. Because I think when you look at this like longitudinally, and especially if these are issues that repeat or crop up over the course of years, and you need to put in more formal, whether they're improvement plans, whether it's remediation, whether it's like probation or things like that, it's really tough to go back and be like, well, we had this conversation maybe on May 17th. I have it in my Outlook calendar, but I don't fully remember what it said, as opposed to like, no, we have 20 different emails over 2 years that have discussed this, and it provides that data should it ever, be, like especially if we talk about like probation and things like that, people can appeal those types of things. So it really benefits the program and the institution to have that type of data to back it up too.
Yes, thank you.
And something that Dr. Evans had talked with me about yesterday is that now there is actually a SLO box where they talk about your administrative strengths. Are you submitting things on time? Are you submitting too many schedule requests? Do you not show up on time for shifts, that sort of thing? So it's asked about. And I think we do a bad job of telling our residents how this is, and our trainees, I'm sort of coming from the GME side, but we do a bad job of telling people why this matters, right? It's like, you gotta get this done, and we're like nagging people and pestering people because it's like, well, we have to meet this criteria for the ACGME, and we have to meet that, and like, these are our bottom lines. But why does it matter to them? And this is really the reason why, right? We're not just trying to nag people to get our own numbers in. I mean, like, that does matter to some degree, but the reason is, like, you could end up sued, right? You could end up negligent. You could end up in front of a medical board just because you never actually sort of learned and took the time to like do the things and form the habits that you need to have. And then you ended up being brought up in front of someone because you didn't answer 6 pages from a nurse that a patient was decompensating, because you never brought your pager to shift, because you never, sort of looked through the guidelines of your department. So if you're not keeping track of these administrative things and really recognizing as a trainee, like, these have knock-on effects in my future professional life. My future employers are going to know that I'm not good at answering emails, right? Like, my future employers are going to know that while I provide reasonable clinical care, then I'm not going to be an easy employee to have, and that I might actually end up sued down the line because my documentation sucks and I didn't say anything about it, and I'm not responsive to this feedback. So there are knock-on issues that are very directly relevant to residents and to medical students that I don't think we actually talk to them about enough. And they hear, I need you to do this for my purposes. I need you to do this because it makes me look bad if you don't, rather than I need you to do this so that you don't run into problems down the line. And so framing it that way, I think, is probably the most important thing, because, like, why do we care about professionalism, quote unquote, otherwise? It's because it's the thing that gets you into trouble. Like, there is the occasional person who has sex with a medical student and ends up in front of the board because of that, but most people end up in front of the medical board because of neglectful things, and because of they're not completing things and doing the things that they need to do, that they know they have to do, they have the cognitive ability to do, but they're just not doing.
All right. I think we're going to move on to case 2.
Okay, so now let's move on to case 2. We're going to talk a little bit about inappropriate call-outs. And so the first case, again, we directed both UME and GME. So our first case is the UME case. A student emailed an attending less than an hour before a scheduled shift to say that they would be 2 hours late due to another meeting. When the student arrived to the shift, they made a blasé comment about knowing it would be fine because no one has to cover for students when they're absent. Does this point to any larger issues in your experience, and what's the best in the worst way that you've seen this handled previously. And then our second GME case is a resident frequently noted to stay 3 to 4 hours after their shift doing documentation. But then they call out of several shifts due to being too tired to work and needing time for wellness. Do you use a Jeopardy or a backup system, and do the residents have to find their own replacement? And then how do you address the tension between the need for wellness and the problems that can be created by this poor time management? And so I would say, why don't we talk a little bit about the GME side, since we kind of focused on maybe a little more the student side previously. Has anyone ever had situations like this? I see yes. I was going to say yes. That's okay.
There was a shift in the bar for how long, we told people for 3 years, just call out with the sniffles, when before it was never an issue. And so trying to put the genie back in the bottle has been a thing. And then we swung way over to it's all about me and my wellness. This is emergency medicine. You were working 20 shifts out of 30 or 19 shifts out of 28. Like, I think the pendulum might have gone too far, and you look like the jerk when you're trying to just shift back towards professionalism. And so this resident that is unable to complete their documentation in time is telling you, I have a problem with professionalism. And then they have more wellness needs and more illness needs. This is the resident that might be a really okay doctor that I am not going to fill out paperwork for when it's time for them to get their job. All I say is, you are going to lose your job. I am sorry. You cannot show up on time, you call out inappropriately, and you don't get your documentation on time. You're a great doctor. We will not be providing you that excellent letter of recommendation that you're seeking. And all of a sudden it starts making sense like January of their 3rd year.
Thank you.
Sorry, I'm talking. I like to talk a lot. No, I as somebody who is in the GME space, this is something that our program is certainly looking at as both a challenge and an opportunity right now. I mean, we do have a full Jeopardy schedule. I mean, full disclosure, University of Michigan, we have 64 residents in a 4-year program. So we do have both the challenges of a lot of Jeopardy activations, but we also have the ability to have a pretty faceted Jeopardy call system, but it still got stretched a lot during COVID and kind of continues to. I mean, I think one part of this is the documentation issue, which is again more of a clinical thing, time management thing, which can get addressed in both informal and formal ways. But I think the larger aspect is the second part of it, how do you address the tension for wellness and the culture that you then build by it or lose with it, and how it affects other individuals. And I think that's actually one of the biggest challenges that fully bluntly faces our institution, our program right now. Is everything that you do has a webbing effect, but then you also need to balance the individual wellness of one of your residents and an individual and what they are going through, but also then being able to have confidentiality and protection for what is going on, right? To some degree, is it mental health wellness needs? Is it illness? Is it short term? Is it family bereavement leave? Things like that? Is it social, familial things, life stresses? And to some degree, every individual needs their own confidentiality with that. So it is really tough to be well, you're on a medical leave, but you're posting things on Instagram right now. And that's challenging. I think by being able to explain to the individuals that this does affect other people, that you try and create a culture of responsibility is extremely challenging, especially when you have people that come at things from different backgrounds, different advantages, disadvantages, different levels. It is really tough, and I think that's what makes a system great to have that type of diversity, but it also provides its inherent challenges. Using Jeopardy backup system, one of the things that we're specifically looking at for next year or enacting is long-term versus short-term Jeopardy call. So by being able to have extra coverage for medical leaves of absence is going to hopefully benefit us a lot. because then it takes like the short-term jeopardy call as like, no, I woke up with a fever and I need to get tested for COVID or something like that. So.
Thank you.
2 points. The first one, going back to this specific scenario, is that this person is saying that they're unwell because they're staying late because they have poor time management. So going to the root of it, poor time management, well, why? Why is that an issue for you? Is it speed? Is it documentation? Is it procedures? Is it everything? What is the issue? Are you coming on time? Are you coming late, signing out late, and then trying to catch up because no, there's red on the board or people to be seen on the board? What is the issue? And maybe being able to have that peer-to-peer conversation, chief resident to senior or junior resident, and personally it was difficult as a chief to have that conversation with a senior resident, or does that conversation have to come from their faculty mentor? Trying to figure out, well, okay, why is there an issue and how can we address it? And if we address that root issue, then maybe we get you leaving closer to on time, and then maybe we get you not calling out as often and impacting everybody else. But I think the biggest challenge, or one of them, is definitely in, well, how do we actually help with the root problem?
I absolutely agree. We've had this issue with residents in the past where we've actually taken time out to have someone shadow and see if there's inefficiency on shift that is causing this. You'll find we've had very talkative residents in the past that like to talk on shift, like to kind of use their downtime between patients as a little bit of kind of that social aspect, and you have to have that conversation that getting your notes done and not staying after to, again, have more of that kind of social time, or spend time not doing your documentation, not doing your on-shift work. And sometimes we find it's easily fixable issues once you sit down and kind of address it root cause, like you say.
Obviously, Lauren and I kind of know some of the same people, but occasionally you'll find that this is actually a medical problem that you might not have anticipated that impacts learning. Whether it's an attention problem, something else that's cognitive, it may be the opening that this person needs. They really are having a problem with wellness, and it's beyond their understanding. And you can be someone who kind of talks to them, uncovers a little bit of that. And then maybe, whether that's the APDs or the program director, it's for them to kind of provide additional resources for that person to reach out, either on their own or with the program support, to find ways to improve their performance that may impact them for their entire career. Frankly, we've seen some really struggling residents who look just like this go on to be just outstanding clinicians, and some of our best loved residents over time, even though we had this period where everyone was very frustrated and didn't understand why these things were happening. So.
That tells you that this is an underlying medical issue?
I'd say I'm not the expert, but some of it comes from those conversations you have. I mean, some of it's their attitude about it, what they're willing to disclose, the way you see them kind of interact with their work. People, sometimes it is having those people follow them around and do some sort of time observation studies that can reveal those clues, but I'm certainly not the expert in that.
Thank you. Does anyone else have something to add? Yes. Dr. Easton.
Yeah, so hi, Travis Easton. I'm from the University of Arkansas. I was Lauren's residency director, so I also know some of the people that she's talking about. I think the GME scenario is really complicated because it potentially includes like 6 or 7 different underlying issues. Like, one of the things that we have done is when we get residents that have this kind of time management issue, we pretty much uniformly refer them for neurocognitive testing. Do they have ADHD? Do they have dyslexia? Do they have some other underlying problem that they're such high performers that their entire life they've been able to compensate, and now they've hit the point where it's just too much and they can't do it. And we've definitely had residents who have resisted that. And we've had some residents who have gone through it and people are like, no, you're fine. You've got some other issue, but it's not this. And so, the other thing, if you take out kind of the stay 3 or 4 hours late, but it's a lot of call outs, like Greg said, is there a medical thing? Is it mental health? Is it substance abuse? We've had those scenarios as well. And the interesting thing about the people who are just like late to shifts, that can go on for a while before anybody figures it out, because the nature of our schedule is that it's not the same people that are there when they're late, right? And so until it's happened to the same people a couple times, it can be really tough even to notice it, because people, sort of human nature is you're kind of like, oh, like it's just, everybody's late sometimes, and nobody realizes that like this person's been late sometimes, a lot of times. And so, yeah, I think there's a lot of different angles to this. The neurocognitive testing has been a good thing for us. We've been lucky; our DIOs have been psychiatrists, so we can kind of like bounce things off them. And then, as far as like the like medical and mental health things, one of the things that our DIO told me very early in my program directorship was that like you're their boss, not their doctor. And so, like resisting the urge to diagnose them or even worse, treat them. Obviously you can't turn off the fact that you're a physician. You're going to have suspicions, and that's where you need to make sure you're referring them appropriately. So yeah, a lot of potential issues here. As far as jeopardy, we don't have one because our residents have always resisted it. And so the agreement that we have with the residents is that we will not have jeopardy until they are not able to fill the shifts that need to be filled. And once that happens, then we have a jeopardy system.
Thank you. Okay, I think we're ready to go ahead and move on to case 3. I'm going to hand off to Dr. Lewis.
Again, thank you everyone for your participation in this small group, so we really appreciate it. So this is a more of a choose your own adventure, not really GME versus UME, but kind of two different issues. But one is, how do you respond to the trainee who consistently fails to submit administrative tasks on time? For example, duty hours, their online learning modules, any required ACGME surveys, or how do you approach the trainee whose lack of timely response to emails is starting to cause significant issues?
To start this off, I think, and there's at least one person in here who can correct me if I'm wrong, but I think that we do this poorly, and we just kind of end up just nagging people on individual instances, right? Like you didn't submit your duty hours, you need to submit your duty hours, you didn't submit your duty hours, your conference attendance is below, and there's just sort of like individual reminders, and that ends up, I think, creating a lot of friction between the residency leadership or the administrative staff and the person in question who is getting nagged. There's kind of a lack of, we hear a lot of, you're treating me like a child, you're nagging me, you're not treating me like an adult learner, you're not respecting me, and sort of like, why do you keep bugging me about this? And recently we kind of swapped from checking things quarterly to checking things monthly, for example, like conference attendance and duty hours and that sort of thing. And there's been a lot of resistance to that as far as like, why are you nagging me? Why are you nagging me? Why are you checking this monthly now? And so I would be really interested to hear if anybody does this better, that we could pick up tips from, because we have not necessarily found a really effective approach.
This kind of goes back to the same issue of professionalism that we saw before, but one thing we did was to really empower our coordinators to poke us when somebody is consistently on that list. After 3 emails, the coordinator sends the names to myself or the PD, and we tiger text them with priority text. And then it's a conversation later in my office about, you need to stay off of the list, right? These are things that are mandated by people with more stake than you will ever realize. If you don't want to get paid, don't put in your duty hours. It's not that easy. You will hold up the whole process for 700 people getting paid if you get too behind on these things. The same thing with the modules, the ACGME survey. We figured out ways to have loop back to make sure that they're being done while trying to keep the anonymous stuff. Some of the other things, we've gone the other way, unfortunately. So when people weren't doing their learning modules, we now have added that in order to progress to second year, you need to have completed those modules the first year and done them in a timely manner. And we hate to be reactionary and punitive, and you always try the carrot before you try the stick. When things aren't working, you just have to gather. The other thing we do is engage our chiefs. What do you think we can do to help people be grown-ups, right? What do you think we can do? Because sometimes there's something out there in the strata that we are unaware of, or we will change something on a platform and not realize that instead of 10 clicks to do it, it now is 42 clicks, and it's much more time onerous than what we realize since we are not doing those things. So engaging your coordinators to kick things up the chain, having meetings with people when they are falling behind professionalism. We love problems that have to do with medical knowledge. We can fix those all day long, right? The problems that we have that will manifest later on down the road are always professionalism issues. And so these are the things we talk about. You have to keep your license up. You have to keep your DEA number. So it's easy to draw that extrapolation once you get them in your office. So empowering your coordinators, your chiefs, sitting down with them to say what this means, and then talking about some of the things that unfortunately now negatively impact the entire residency because you 3 or 4 couldn't get it together. Sometimes has a little bit more, but some people don't care. And some people you have to look for a different reason just to figure out why. And sometimes that's on us.
Yes, thank you. That was excellent. We do similar. We have our Educational Executive Committee every month that these issues are brought up and are addressed kind of in real time with our APDs emailing out. That's kind of our strategy to get at least trying to figure out the bottom. But it really is speaking with the person individually, understanding where the lapses are, but explaining why these things are important. I think, as residents and trainees, you see these tasks, you don't necessarily think about them as important to everyone else in holding up the group, but just explaining how these impact your job going forward and your recommendations going forward is essential. Has anyone else had any experiences?
Hi, everybody. My name is Mary Haas. I am also from the University of Michigan, like the lovely Dr. Thomas. And I know Dr. Thomas is actually engaged in a really innovative effort called the Intern Development Group, where she's been meeting on a recurrent basis with our interns. And I think there is some specific teaching around professionalism when it comes to communication. And I've found that to be like one good approach, having kind of not quite a peer resident doing this teaching, but somebody who is like a more junior faculty in an APD role where there's that like psychological safety to kind of do some coaching around the basics of professionalism. And then I do remember an experience. We had a trainee who really classically struggled with inbox management, and she was an excellent resident, excellent human, but this really did become an issue for her. And part of the problem was that her inbox was so full that it was like so overwhelming to her that she could never catch up. So our program director had to do some specific coaching with her and ultimately like sat down with her and had her just delete her whole inbox and start from scratch. And just like that totally revolutionized her approach. And once she could like start from scratch, she could finally keep up again. And that was a really powerful moment for her. And from then on forward, she, did a lot better with email management. So sometimes I think it is a matter of actually just like starting from scratch.
Clean slates can definitely help in some of these instances.
The last thing that I'll add is we found some of our trainees also have issues with email as well, and the email inbox. And sometimes we can have our coordinator send a text, and we get an immediate response of the ACGME survey gets completed. And it's not feasible with a large group, obviously. It's not feasible with a large residency, but sometimes in the interim, while working with residents who struggle with some of these issues, we found that giving them that reply so that they aren't constantly on that list can help them as well. Yes, thank you. Okay, we're going to move on to case 4.
Tardiness. A student always seems to be late to required non-clinical activities, including group didactics, simulations, and journal club. Often the whole group has to wait until they get there to begin. How do you as the clerkship director address this with the student? Or how do you as the supervising resident or supervising attendant of the specific event address this in real time? On the GME side, a resident always seems to breeze in at or slightly after the start of a clinical shift, delaying sign out until they can get set up, signed in, and ready to proceed. As the chief resident, how do you address this? As the co-resident, how do you address this? And as leadership, how do we address this?
Hi, I'm Emily. I'm one of the chief residents at UConn with Aisha. So I think it starts with the chiefs before escalating it to like leadership, because I think there's more of a level of trust between the other residents and less like you're scolding them because it's coming from a co-resident. I usually start the conversation with, hey, we've noticed that you've been coming late to shift, and like one-off time I don't think is a problem, but if it becomes a pattern, you know, what's going on? Is like there's something that's preventing you from getting to your shift on time? Like, are you having car troubles? Are you having family issues? Like, is there something that can be addressed that's not just you not caring about coming to work? So I think having an open conversation about, is there something that we can do to help or leadership can help to get you to your shift on time? And if there isn't a good excuse, or you know, you make the efforts to help them and it continues to happen, then it needs to escalate above to, you know, the mom and dads of the residency to deal with it because it's out of our hands.
Thank you. Okay. It's always interesting as a co-resident and not as a chief resident, so being in second year and kind of your fellow second year come in late and you're like, what's going on? Everything okay? But I found it was a bit more difficult to have it not as a chief resident, where you couldn't quite scold them for being late, but you wanted to have that conversation. What about with students?
This is a characteristic. I talk too much, so I apologize. I think a lot of this goes back to what's the big deal, right? Like everybody says, what's the big deal? I was there a couple minutes late. Like, why is this a big issue? And one of the things that comes out of the literature search, which we did, so you don't have to, very dry articles, is that a lot of these attendance issues become a concern, right? Like it's this repeated pattern of just a little bit late, just a little bit unreliable, just once in a while doesn't show up, you know, not really a reliable kind of like organized person. That is the number one thing that is associated with being sued and with being censured or brought in front of a state medical board, is irresponsibility. It's not, again, I hate keeping returning to this, but this is one of the things that I think we don't communicate with people, again, is it's not clinical incompetence. It's not like a knowledge gap, and it's not the things that we usually teach during residency. And a lot of people will say, well, you know, why can't you just let me be an adult? Like, these are the things that are associated with actually big ramifications to your career. So the big deal, I think we need to do a better job, whether that's, you know, as a chief resident or as a program director, we can actually point to literature about these things. And I don't think that oftentimes we think that we can because they're soft skills, but we can really point to numbers and say, you are 8 times more likely to be in front of a board if you continue with this pattern. People who have done the same things as you have are 8 times more likely to go in front of a medical board. You don't want to get sued. Being sued is terrible. We all know that. And you don't want to necessarily be brought up, even in residency, being brought up in front of your program director and not being recommended for a job, big deal, right? Like, you have to get a letter of recommendation from your program director for your next job, whether that's fellowship, whether that's your next employer, and they do not have to say, this resident is great, wonderful, and perfect. They will be asked, like, how are they administratively? Not great. You know, they have to say that. That's their responsibility. So, like, it is, I think a lot of times, what's the big deal turns into, we have to actually say what the big deal is, right? Like, we have to communicate that with people. And oftentimes, I don't think that we think we have the tools to do so, but we actually do.
Awesome, thank you. I think I'm going to hand.
Yeah, I think that we've kind of reached our time. We had one more case, but we've kind of reached time, and we really thank everyone for the great discussion and great input of the different cases that we brought forward, because we know that this is, again, something that programs across the country struggle with, both from the GME side and the UME side. So it's great to start these discussions of how different places handle it, and you know, potentially come up with some best practices that can help other programs and help others who are in a similar situation. So thank you so much for the great discussion, and thank you for joining us this you know, busy sauna game morning. We appreciate it.
Hello. All right, it's exactly 11 o'clock. Should we get started?
All right, everyone. Thanks for coming to our didactic, and hello to everyone who's watching at home. So my name is Alexandra Nordberg. I'm the Assistant Program Director at UMass Medical Center in Worcester, Massachusetts. And this is our Education Committee-sponsored didactic, looking at early career planning, avoiding pitfalls, and trying to set yourself up for success early in your career. And so this is everyone here on our panel. We are going to go through introductions in just a moment. We have no financial disclosures. So our objectives here, we're going to anticipate common challenges early in your career, brainstorm strategies to prepare and overcome them, and also help you develop a personalized plan for yourself as a way to, kind of prep and move forward and be ready to succeed early in your career. We thought this was important considering that within SAEM, as an example, there's a lot of support for medical students, there's a good amount of support for residents, and then there's kind of this gap, and then there's mid-career support and things like that. And you'll hear a lot of support for junior faculty or mid-career faculty or like senior leadership and opportunities in there, but we identified this kind of, gap where it's kind of like you take this jump into a completely different position, going from resident to attending, or kind of like you're junior attending and maybe you have this new leadership role or something like that, and there's not a lot of talk about how to kind of manage that on your own from like a personalized standpoint. Oh, and this QR code that we have, so this is a way to ask anonymous questions if you would like. We know sometimes that with these maybe more personal topics, you might feel uncomfortable asking a question in front of other people here. It's totally fine. You can use a QR code that'll be on each slide, and you can anonymously submit questions that we will monitor in real time. So like I said, I'm Alex Nordberg. I'm the Assistant Program Director at UMass. I finished residency at UMass in 2018. I am a Rams alum. I was the first president of Rams back in the day when it first started. I also completed the Armed Med Ed course, and currently on the education committee where I met these awesome people. As a personal introduction, I am married. I have one child who's 16 months old, and one very energetic dog. And really, at this point in my career, trying to balance, working on work-life balance, which is very challenging right now. So that's me.
I'm Miriam Kulkarni. I am the program director at St. John's Riverside Hospital in Yonkers. I've been in EM for 15 years. I've been on a bunch of SAM committees, as you can see. I am married. I have 3 kids. I have a daughter who's 10 who has autism, and I have now my twins are 9. They just turned 9. And definitely have spent a lot of time in that space where I'm sort of juggling, kids and the demands of my residency and sort of the demands of my own academic career and academic advancement.
Hi, I'm Sandy Werner, and I'm kind of the more seasoned representative in the group. So I have just a few more than 15 years in emergency medicine. I'm currently the vice chair at Metro Health Medical Center, Case Western. I have been on a number of SAEM committees and chaired a couple subcommittees and all that kind of good stuff. What else am I supposed to say? Anyway. I'm actually from Colorado originally. I just bought property there, so I'm thinking I'll go back there sometime soon. I'm married for over 30 years. We don't have any kids, have a couple horses, and I'm kind of here to set the perspective of like how to survive a career and how not to make the mistakes that I did. So that's kind of my role here.
Hi, I'm Meredith Von Dolan. I am probably opposite of that. I'm the youngest, I think, in emergency medicine. I am the clerkship director at UAMS, which is the University of Arkansas in Little Rock. I also am married. I have 2 young children. I've been faculty now for about 3 years. I've also been part of the our Med Ed group, which is actually, I think, where I met Alex, and also on the education committee and the faculty development committee and the DEI committee. But I've been on quite a few committees trying to figure out what I like and kind of involvement.
This seems to be on, we think, so try it.
Yes, I'm Daniel Jordan. I'm the Rams president currently. I'm a 3rd year at Henry Ford in Detroit. I've been on a number of committees: education, research, mentorship, nominating program. I'm primarily here to moderate, which is why I have my phone out. I'm looking for any questions from you all. I'm not just texting, so that's all. Thanks.
Alrighty, and then so I'm going to take a seat, and then Dan, if you want to come up and do our slide advancement. All right, so our first topic is personal professional integration. We purposely called it integration and not balance. As you'll commonly hear, balance implies that at any given moment you're striving for balance in all things, which is not true. You are striving for overall balance, but this sense of the visualization of like that seesaw that's perfectly balanced is not true, because at any one moment in time, things are not balanced. You're choosing at any one time to do work and be committed to work, or you're choosing to be committed to your personal life, whatever that means for you. So some people are just better at this than others. Like I had said before, this is an area that I'm really working on for myself right now with my new family and kind of the demands that everything brings simultaneously. I think for me, having a support system is so important. My husband is so supportive and has a job that allows him to have more flexible hours to kind of go around my schedule a little bit more. So I think it's whether you have a significant other or finding colleagues at work you can lean on from like a personal lens. I think that's super important and something that is going to really help you succeed in that first job after residency.
I would echo the importance of sort of choosing the right partner and communicating clearly with your partner. My husband is a teacher, and especially now that our children are school age, like, you know, he's free when they're free, and it really has sort of allowed me to have a lot of freedom, right? I'm here, my children are, you know, in Westchester, New York, where my husband is. And I think, you know, when you are entering into a relationship, in the relationship that you just have to really be sort of upfront and communicative about what your career is going to look like. And I mean, I think the other sort of trade-off that I make is that when I'm the breadwinner for my family, so when I am contemplating changing a job, for example, that is something that I absolutely do in conjunction with my husband. And when I accepted the position that I have now, it's absolutely something that we talked about. And I sat there with him, and I like the whole salary package and benefits package and everything about those positions. We absolutely had a conversation with. And I think that that's tremendously important to sort of think about. But I could not do this without the partner that I have.
Yeah, it's kind of taking the long view. Negotiation is really important, and also considering what you have to do versus what tasks can somebody else do. So if both of you are in residency together, which can be tremendously difficult, you need to like look at things, you know, can we get our food delivered? Can we have pre-cooked meals? One of our residents, we had to have a day every so often where they can, you know, just tell us like the cool stuff they found. And one of the residents came and she said, I just found the best thing in the world. I found a laundry service that will fold, they'll wash my clothes, they'll fold them, and I get them back the next morning. And I swear that half of our residents by the end of the week were using that service because it was cheap, but it allowed her to have the time that she needed to do other stuff. She happened to have a kid, you know, she previous to residency, so she had a 4-year-old, and she was like, this is just for me. And you know, it allowed her to use her time wisely. So think about things that you can outsource from your cleaning, whatever, so that the time that you're not working, you can actually use that time to spend with your family. And the other thing is you have to schedule time off. So when you are on vacation, you are on vacation. And you really need to make that clear in your mind and in your boss's mind, that you know you are not going to respond to emails, etc. So I'm vice chair, which basically means that you know if my chair is off, I'm like that person. And he's the kind of guy who keeps his phone with him all the time. And I told him, you know, when I took that position, I said, you need to understand I am not like you. I will not have my phone on when I am on vacation. I will not respond to emails unless it's something super critical, because I'm not like you. I'm not going to be plugged in when I don't have to be. That's like really critical to maintaining that balance. So don't allow job creep. Just be really clear on that. And yeah, there's going to be times when, like so when we had COVID, I was in charge of the COVID medical care protocol. So I had to work with all of the different departments because I happened to be medical staff president at the time. And I told Greg, I said, for the next 3 months or whatever, I'm simply not going to be here. I'm not going to be available. And then, right after that, as soon as I could be clear, I said, okay, now I'm going to take 3 weeks off and not do any work. So just, you have to kind of communicate that stuff, and there's going to be an ebb and flow, and make it clear at your job too, that yes, if I'm going to commit 12 weeks to this project, then I'm going to, work a normal or less than normal schedule afterwards, because I need to have that integration.
So I'm a big proponent of the saying, you can have it all, just maybe not all at the same time. And I think that's traditionally been used a lot in reference to female physicians, but I really feel like that applies to all of us. Like, for me, yes, it has a lot to do with my family, my children, but it also, I was just telling Alex earlier, like, I have to schedule time to work out. Like, these other things that are really important to you, whether you have a family, whether you have a partner, you're single, or whatever is important to your life, you really have got to define what is your top priorities and then create your boundaries to align with your top priorities. So it's really easy, especially early in career, to say, yes, I will help with that. And yes, I'm going to help with this project. And oh, I should really help with that. And now you end up having your plate so full that I will tell you, when I first had my first child, I'd put my child down to sleep, and then I would every night bring out my laptop and work on things. And I finally got to the point where I realized that wasn't how I wanted to spend every night. And so you just have to figure out what your top priorities are and then align your boundaries to meet those. It's okay to say no early in career. And I remember someone telling me that, and I will tell you, I probably didn't listen, or I didn't think it was as important, but it's okay to say no to things that maybe aren't as important or that you think may not get you to your end goals. So kind of defining that early on, I think, is especially important, and that's important kind of for everyone, right? So whether you're willing to spend all that extra time, unpaid early in your career because you think that or know you'll get that back later in your career, that's okay. Or if you're deciding, I don't have that time right now, and maybe I'll commit that time later, you just have to make those decisions early on and then kind of be true to those priorities and values.
Yeah, I will just kind of add a little bit more to that. So especially when you talk about having a job in academics, the line between your time for work and your personal time is so easily blurred. And I think that's something that we don't really talk about a lot, yet we all struggle with, and how to literally setting physical time barriers in terms of, this is my family time, this is my personal time, this is my workout time, and I'm not doing charts, and I'm not looking at email, and I'm not responding to these phone calls, that sort of thing, because that's the only way that you're going to protect yourself for your career longevity, right? To actually work full-time emergency medicine throughout your career. And things like SAEM, fantastic, and you're going to be bombarded with opportunities to do this committee and to do that project, or something comes up at your institution and someone's going to ask you to do something. But 100%, don't say yes to everything. Say yes to things that are in the wheelhouse of what you want to go into. Don't say no to everything, because then opportunities won't come along. No one will ask you anymore if you say no to absolutely everything. But you do have to protect yourself to some degree. No one else is looking out for you. You are looking out for you. So protecting your time is very important.
So I would say just a couple of other really quick thoughts. And one of them is, in terms of deciding what to say yes to and what to say no to, make sure that you follow through on the things that you say yes to. Because you don't want to have the reputation for being someone who accepts things and then kind of lets them fall flat. And that's one of the big dangers in terms of saying yes to too many things. The other things that I think weren't apparent to me when I was just starting out in my academic career. So there are some things that about being an academician that makes it harder. Like all of us were saying that there's kind of job creep. But there's some things that make it easier. I mean, right now, I work about 1 clinical shift a week. And when you're working a clinical shift, I mean, you have to be there when it starts, you have to stay there until it ends, right? And there's no flexibility there. The academic stuff that I do, a lot of it is incredibly flexible, and I can do it from home, and I can do it, in my pajamas after my kid goes to sleep, or if, one of my kids is sick at school and someone needs to pick them up, I can leave and go pick up my kid and finish my day from home. Like, there's a lot about academics that really facilitates being a parent or pursuing other interests that you have. And the last thing that I kind of wanted to say is, especially if you're deciding that you're going to have kids, or especially if you have a really strong interest outside of emergency medicine, I think it was tempting for me to kind of look at people who had graduated from residency with me or graduated from medical school with me and kind of look at their time frame and be like, well, they're already PD or they're already vice chair and I'm not those things. And I think that that's another thing that you have to kind of your time frame is your time frame, and you do things when you're ready to do them, and your career kind of follows on its own trajectory. And as long as you are fulfilled and happy and learning in the place that you are, give yourself some grace and don't compare yourself to other people.
I would just add, look at if you're an academician, you also need to start early looking at what your requirements are to get promoted.
Yeah.
And say yes to things that are going to help you in that trajectory. And when you say yes to something, make sure you know exactly what you're saying yes to. So I recently, one of my colleagues in infectious disease said, hey, will you help me with this NIH grant? I have never filled out an NIH grant proposal before in my life. And I just said, well, of course, because I'm all into HIV testing and the ED. Well, that was a mistake. I should have said exactly what you need me to do, because it turned out to be a lot of work. And if we don't get the grant, I'm going to be really unhappy.
Any questions from the audience? Yeah. Oh, yes, and if you guys don't mind, coming to the mic so that we can get it for people watching from home.
So kind of along the lines of the topic of kind of managing your own time and everything, what I'm starting to realize is now that I'm working in a lot of groups, I'm terrible at managing my own time and taking on too many things, but now I'm waiting on timelines of other people. And so I'm falling into the trap of they turn something in last minute. Now I have to compress time and do all my things. So kind of what, to meet a deadline or something. So kind of how do you maybe communicate that with, your boss of these people aren't helping with my timeline, or, how do you have grace to let something totally fall through because, other people weren't kind of helping you meet those deadlines and everything?
I think we could have a whole separate talk about managing, working in groups.
Team management. So if you are I will say if you are a team leader, that means that you're taking on the responsibility to get your team to the end goal. And so there's obviously an end deadline for whatever, it's a grant proposal or something. When you have this is a whole there's lots of discussions and books about how to run meetings and what can be an email versus a meeting and things like that, but you're going to be succinct, you're going to give people definable tasks, and you're going to give them deadlines for those tasks that are way sooner than the end overall. And you're going to give them deadlines knowing that we're all emergency physicians and we will all do this at the last minute, and they'll be like, oh man, I needed more time than you said. So you as a team leader are going to set deadlines for different pieces of your overall big project so that you will have a grace period of 2 weeks or some time for you to get everything together and finalize it before your presentation, before your grant proposal, something like that. So that is definitely tough. Also something that, you'll get voluntold to lead a meeting or something as a junior faculty, and you kind of feel like you have no idea what you're doing. And learning to manage people and manage a team is definitely a skill. So definable tasks, set deadlines that are way sooner than the actual real deadlines.
And send out ticklers,
Yes.
right?
Yeah.
You want to remind people. And you
Yeah.
can even schedule these like through your emails that, hey, you have this project due on such and such a date. That will help them get done. And then also, remember, if this is something you're ultimately turning into your chair and somebody is just not doing it, it's maybe it's going around maybe it's going around their back a little bit, but I will say, hey, I'm having some difficulty getting this person to do the task. Or I will reach out to the person and say, hey, I really need this. If you're not going to be able to do it, I need to know it now, because I am responsible for this to be turned in, by such and such a date, and that means I'm counting on you guys. And if somebody says, I just found out, my mom has cancer or something like that, then okay, we're gonna find somebody else.
Right.
So that's useful too.
I was going to say what helps me and is figuring out how the people in your group work. So me personally, I work really well under a deadline. All the other times I just kind of like, well, this could work and that could work. When I have a deadline, I know I have to put something down and get it done. And so for me, that's the time I reserve to do it. So when I work on a group, I try to figure out how the other people work, because some of my colleagues where I work now, they like to do things way in advance. That just works for them. That's how their brain works. They like it that way. And so if I know I'm working with those types of people, then I will try to give myself an earlier deadline. But it just kind of helps to know how the other people on your team work and function and how their brain works. And so that could maybe help you. That way, if you know that they are like me and like to work under that deadline, then like Alex said, right, you can bump up that deadline and give them that firm deadline, but still gives you enough time on the backside so you're not feeling like you also have to work under the deadline like they prefer.
I think in the interest of time, we're going to move on a little bit. So our next topic, self-advocacy and finance and negotiations and that sort of thing. So from a topic of finance, I will say that it is so easy as a resident or a fellow to put blinders on to every real life stuff and to be retirement, I will worry about that when I have a job that doesn't require me to work 24/7, things like that. But I would encourage you to, while you are a resident or especially junior faculty, to really consider this your first year out of training. You should make a budget and stick to your budget, keeping in mind that it is important to treat yourself, right? You're doing really hard job, there's a lot of mental and physical load that goes into being an emergency physician. So you need to treat yourself. That's part of being, a person and enjoying life, but just making sure that it fits with your overall financial goals. We talk a lot with our residents about disability insurance. I won't belabor this, but you want disability insurance and you want to get it when you are young. Mm-hmm. It is a little bit expensive. It will probably run you a few $100s a month, but the younger you get it, the cheaper it is. And if you get it when you are a trainee, then you get locked into a discounted rate. You want your disability insurance to be own occupation, meaning if you get disabled for whatever reason and you can no longer work as an emergency medicine physician, you will get your disability payout. There are lots of ways and resources to go about doing that. There might be someone at your institution that you can reach out to, but that's definitely something to look into while you are still in training, kind of like a small piece into kind of your overall financial wellness as you move forward in your career.
I think we should talk about sort of negotiating within the professional space.
Yes.
This is definitely not something that I had any experience with or really had thought about before I was in the position to kind of do it. So first of all, before you start a job, before you accept a job, you and the person who's employing you should be on exactly the same page in terms of what the expectations are, what the metrics are going to be in terms of whether you're doing a good job, what the compensation is going to be, what the sort of parameters around you leaving the job will be. And when you are getting the contract and signing the contract, that's the chance for that to happen. Once you've signed the contract, you've committed to something, and it's much harder to change something if you don't, if you would have wanted to change it. And not only that, if you start a job and you and your employer sort of have a different vision of what that job is going to look like, you're kind of setting yourself up to have a difficult time. Another thing, so make sure that you have a completely upfront and candid conversation especially if you're taking an academic position, especially if there's protected time involved, because there are going to be expectations around that time. And they are going to have deliverables that they expect from you, but sometimes people are not explicit about what that means and what they're looking for. And academic time is incredibly expensive. I did not realize this until I accepted the position I have now. And my current employer said, well, an hour of academic time costs us $10,000, it was like eye-opening for me, because I knew it cost money, but I had no idea how much it was. And I actually think that that's probably a pretty good number. It may be up or down depending on where you are in the country, but it's about that much. So if someone is giving you 2 hours of protected time, that is costing them $20,000 a year. So you have to deliver $20,000 worth of product. But that has been, that is like absolutely key if you are thinking about an academic position, if you're accepting an academic position. Make sure that you understand what they're expecting from you. Make sure that you understand what success in that position looks like. Because I definitely have had a lot of colleagues kind of get themselves in trouble. And now as program director, have put people in trouble when I don't think that they're delivering enough for that time that we've given them. So make sure that you understand what the expectations are, for sure. And when you're asking for protected time, understand that it's an expensive thing to ask for.
Yeah, it should be dedicated time. So not just protected, but dedicated. And it's dedicated to something of value to your department, to your institution. So it's not like they're giving you something. You are providing them a service that they are willing to give you that much time to do. And for women in the audience, I can't remember the author of this book, but there's a book, it's called Women Don't Ask. And she wrote another book accompanying it, and you need to read those books before you go into any negotiation, because we think differently, and we don't ask for stuff. In fact, there's good data that shows for jobs, men who have 60% of the qualifications will apply, but for women, and we read the job description and we say, oh, and we don't apply until we have 80 to 90% of the qualifications, or we feel that way. So our self-worth, we perceive ourselves as being less worthwhile. So, man, you really need to look at that, and you need to ask for transparency. What are your colleagues getting? Make darn sure that you are getting the equal thing. And if that information is not shared, I would think strongly about not working for that group. And you need to ask about how positions are, how positions with dedicated time are, how is that decision made? In my department, up until fairly recently, it was basically the chair would come up to you and ask you, hey, I think you'd be good at this. We did not have an open application process. And I felt that was absolutely wrong. So now all of our positions, if you want to be operations director and that becomes open, if you want PD, associate PD, assistant PD, whatever, it's now done by application and by interview. And I'll tell you, we got a new PD that I had no idea had any interest, and he's fabulous. And if we hadn't done it that way, he wouldn't have been picked. So, and just remember that. And remember, especially if you're a woman or an underrepresented minority, that there's a minority tax, and you need to make sure when you discuss with your employer their expectations that you need time. If they're going to expect you to sit on all the DEI committees and do all of that kind of stuff, that you need to have the time to do that, but you also need to have the time to do your academic work. So that's a super important item in negotiation.
So I 100% agree with that book. I actually did a book club at our institution based on the book, and it was phenomenal. So I highly recommend to read it. I think most of us already know it. It's just like we have to be told it. We're really bad at negotiating traditionally, and it really helps you get to a better place. I would say, just real quick, self-advocacy is the number one thing or number one skill I really feel like you should learn early in your career, because you're going to do it all throughout your career. Some people are more comfortable with it than others. I tend to be a little bit more uncomfortable, so you really just have to lean into it because it's not going away and you're your best advocate. So if you can kind of be more comfortable and learn how to sharpen that skill better now, it's going to serve you the rest of your career.
Do you have a question?
Two quick questions. One, what was the name of the book again?
Women Don't Ask.
Thank you. The other question I had, specifically related to self-advocacy, is specifically, what ways do you recommend going about it in the academic setting? And I think one of the problems that kind of leads up to that is I feel it is hard to clearly delineate what value you provide as an educator versus like, I brought in this grant funding, or like I generated these RVUs, where it's harder to delineate like, I taught really well. And so how do you advocate like, no, I want this buy down, and for me, it's not even so much the money, it's that like, I want to make sure, because I'm willing to accept less money, I just want to make sure you're still valued for what you do. So how do you advocate for a contract in a way that like demonstrates that they value you, know that you're valued in that way and that your work is valued, especially when, because I was at a talk earlier where they kind of talked about like, at faculty groups for like academics, like how much room for negotiation is there? And a lot of times they say like, no, here's the base pay. They might have like plus like a bonus and or plus like depending on like a RVU bonus or things like that. But they're kind of like, there's not a lot of wiggle room. So how do you make sure you actually advocate for yourself and get the protected time you need or make sure you're valued?
So you're right. There may not be a ton of wiggle room in terms of the salary. And I think that is a model that a lot of groups are adopting specifically because they want to be more transparent, right? And they want to say, everyone who we hire fresh out of residency, they get, $100 a year, and that's how much we pay. There probably is more wiggle room around how much dedicated time you have, for example. So that's a way that you can advocate for yourself in terms of, well, I'm going to give, I gave 5 talks at SAEM, and I'm, heading this committee, and I, started this program for the residents, and that's usually there's more wiggle room around that. The other thing that I have advocated for on other people's behalves and told them to advocate for is if you decide that you want to say, I don't know, take over the research program for your department, you can say, can you send me to ARMID, or can you send me to Merck, and can the department pay for that on top of my CME? And when you get benefits like that, the other thing to kind of keep in mind is they're not taxed, right? We are in a very high income bracket. We're very heavily taxed. Any dollar that they give you, a third of it is taken away by the tax man. But if they send you to ARMID, if they give you, 4 extra hours of dedicated time, if they give you more CME, those things are not taxed. And so they actually are worth more. And a lot of times there's more wiggle room in those things, particularly with the idea of, like, if you say, I want to do a master's degree, can you pay the tuition for it? Like, it's particularly around the idea of training you to better assume a role that they want. And that also sort of advances you and gives you credentials that you can use if you, decide you want to leave later.
Yeah. The other thing I would say is align your request, your advocacy with the institution and your department's goals and mission. So if one of your department's missions is to, better educate the residents or whatever, you can say, we lack anybody with a med ed degree. And, it would be great if we could if we could do a med ed fellowship, and I am willing to take on that role if you will pay my tuition to get this master's degree. So they're going to pay and you know, provide me the time to take the degree. And here's what I will provide for you. But if you tie what your desire is to the department's goals or the institution's goals, that will make it so much easier for you to advocate for your desires, because then it becomes, hey, here is what I can do for you. And that I have found has been super useful. I've gotten lots of stuff paid for.
Yeah, that's also the
by
basis
doing
of the
that.
book Getting to Yes, which is
yes.
a book about
Yes, that's a great
negotiation.
book.
It's a pretty easy read. It is like basic skills. It's like self-advocacy 101, Getting to Yes. Quick, easy read, and tells you how to frame your thought processes, how you're going to have the conversation, what you're going to say, things like that, in terms of so both parties get a positive net benefit out of the topic that you are negotiating.
The other thing I was thinking about when you asked that question was they like to see outcomes, right? So if you're already doing all the education pieces, creating some kind of outcome measure, whether that's increasing your residents' knowledge or your medical students, or, you know, that your students are more engaged, or your students want to become part of your department more because of your efforts. Some way to show them, like, this is what I'm interested in, and look, I'm already doing it. So how, you know, and then you can ask for what you want, right? Like, that's another way, especially, I know all of us in our education, right? We're already doing it. I think we're just not as great about showing those outcomes. And it's kind of hard in education, but there's definitely ways to do it. And that can make your ask even stronger. Like, I'm already doing it, and I can add X, Y, and Z to that. And this is what I would like to help me get there.
And then on that, how do you decide when to, I feel like when you say, I appreciate that, put it in writing, it might be kind of like poorly received, but also like if it's not in writing, it's harder for them to have to honor it. Like, where do you kind of decide, like, when like, no, we really want to support you in like teaching, but then it just becomes like, oh yeah, you had this buy down and we're asking you to do X number of things. And so making sure you're actually advocating for yourself and making sure you're not kind of getting worked a little bit.
Annual performance evaluation time, because it's kind of like a mini contract. And so you're going to go in there and say, you know, and usually you're provided in advance, but when you come to do your APE, part of that, it's written in there, is that you are going to be provided time and money to do X, Y, and Z. And so it's actually written down.
I mean, I think even if it's outside of that time, if they have, you know, changed your clinical hours, if you've taken on a different role, if now you're APD, then I think that's the time to ask for it, to say, is it possible for me to have a revised contract that reflects my different academic hours? If what they're buying you is, say, tuition to a master's program, just emailing back and forth is enough of a written contract, right?
Yeah.
That you can say, just to confirm, I'm applying to, you know, Jim Bob's fantastic master's degree in education program. The tuition is X per year. It will be reimbursed by the department. It will be paid up front by the department.
And having that in email is sufficient?
Yes.
Yes.
Okay.
So the other thing is that if you get out of a conversation where something was agreed upon,
follow-up emails,
and you can go back like the second you are done with that meeting and say, like, email the person, CC, who maybe someone needs to be CC'd, whatever, and say, you know, I just wanted to thank you for your time. I really appreciate it. I just wanted to summarize what we had agreed upon. That way, it is in writing. It is in that email, and it is traceable. And that's how you are able to advocate for yourself and keep other people accountable for the things that they said.
Awesome.
I do an email every time. Like, if I go into a meeting, I'm like, hey, I'm interested in X, Y, and Z. I send an email within like 24, 48 hours. And I'm like, hey, I'm just following up. I just want to make sure that, you know I'm still interested, or, you know, whatever we're talking about every time.
Right, and even if you haven't gotten the outcome that you want, right? If they said, you know, you said, can I have, you know, 3 hours of dedicated time for this, and they said, well, I want you to publish 50 papers first. You send them an email that says, just to, to reflect our conversation, that once I've published 50 papers, then I will have 3 extra hours of dedicated time.
The other thing is that many institutions have deals with other institutions of higher education, and you get your institution to pay the bill so that you're never involved in actually doing the financial part of it. Yeah. I just wanted to also advocate for getting a coach. So if you're at the point where you're not sure what you want to do, you have difficulty advocating for yourself, it's, it used to be kind of like weird stuff getting a professional coach or a life coach. I have to tell you, I'm now currently taking the, getting my certification in coaching, and yes, Metro is paying for it. But I had a new position that I wasn't expecting to take, and I didn't know what to do with it. And as part of my negotiation, I said, I need a coach to help me do this. And you can hire a coach on your own, and man, they will work with you to develop not only what your desires are, but how to get them out of whoever you're trying to get them out of. So it's a little expensive, but man, if you're really stuck, get a coach.
Thank you.
All right, and then, so kind of moving on to our last topic, professional development and climbing that ladder. And we've talked a little bit about advancements and promotion and things like that. So when you enter the academic realm, a lot of your pay and, your title is based on promotion process. And so SAEM, being involved in SAEM in these committees is definitely one way to do that. And it is relatively easy, and to continue to stay involved as a resident in junior faculty. It's a matter of watching your emails for signups for committees, joining a committee. We all join the education committee. And then using SAEM as an example, each committee has objectives. These objectives are then tasks, and each objective has a leader or a co-leader. So that's like a leadership experience. And then you develop a deliverable, this didactic, that this is all going on our CVs as part of, a national conference, involved in a national committee, co-leading a subcommittee for a national thing. Those are 3 things from this didactic, that we're all putting on our CVs. And, certainly there is a balance of you do the things that you do in academics because you are passionate about it and you believe in it and you want to help others and serve emergency medicine. But then there's also you have to, it's a little bit of a game. You got to play the game too. You got to make sure that you're filling the boxes so that you can promote, so that your career can move on as well and have the trajectory that you want it to have. If you're fine with where you are, fine, you're fine with who you are, that's awesome. If you have a goal that you want to get to the next step, you have to keep in mind what steps you need to take to get to that next point, which is, doing the publications or the committee involvement or the national speaking presentations, things like that. So kind of using SAM as an example, it's a great way to stay involved in your early career, kind of help you figure out what niche you want, mentorship, meeting other people who are going to help you get to where you want to be in your career, and that sort of thing. So just kind of, keeping a mind on how your career trajectory is going and what you can do to help it.
Should we go through the slides?
Yeah.
So when you join an academic institution, read the promotion guidelines. What do I have to do? I actually meet with, when we hire new physicians, I meet personally with every single one of them. Initially when they come on board and after their first year, and then I usually can assign them to a different mentor. But that part of that is, here's what it takes. So you need to design your yeses and nos around what's going to get you promoted. You need to know if your institution has a requirement, a time requirement to get promoted. A lot of places are doing away with that because it now, because it places an undue burden on women, on anybody who has to take some time off to be a caregiver, anyone who has like a significant illness. You know, you have this 10-year deadline to get promoted to associate professor, and you have 3 kids, or, you know, your mom is in palliative care for 2 years and whatever, those timelines are unreasonable. So a lot of places are doing away with them, but some of the big institutions still have them. So you need to make sure about that. And then you need to look at it, and that will help you frame what you're going to say yes to and what you're going to say no to. I sit on our APT committee, and we get people who want to be promoted, and they've done all this stuff at CASE. But you know what? It doesn't matter. If they don't have a regional presence and a budding national presence, they won't get promoted to associate professor, period. End of discussion. I don't care how much stuff they've done. I can't do it. Anyway, so, but there are so many things in SAEM that you can get involved with that will help you along the way. And there's kind of this career roadmap. The SAEM website is a marvel. I mean, there is just more stuff on there. I just became co-chair of our DEI committee, and I found the SAEM curriculum on that, and I was like, holy cow! So there's just so much stuff on there that you can use, and this is a great way to kind of help you with your career, your roadmap, and so you can actually navigate to that page and take a look at it.
So the roadmap is like a little bit of a manual for how to get to a specific place in your career. But there's stuff at SAM for like every stage in your career. So there's RAMs.
You wanted to speak to kind of your...
RAMS is awesome. If you're here, you're already a member. That's literally the barrier to join. From there, you join any committee. You end up working with wonderful folks like the 4 of these people here, doing didactics. Running for the board is actually a low barrier to entry to be on the board. Usually we just look for any national involvement whatsoever. You end up working on national products, such as like that roadmaps on the previous page. All the faculty are super interested in working with you on a ton of stuff, even stuff you don't have any idea about, like avoiding pitfalls early in your career, such as me. I'm still doing that. So no, as a RAMS president, I would say I truly encourage you, just get involved. If you just go to a committee meeting, that's all it takes. Then somebody's going to tell you to do this. They're going to assign you times to meet with people, and all of a sudden you're standing on the stage having no idea what's going on.
So I would definitely, real quick, add to that. Like, there are so many opportunities within all the committees to do things on your own time. So even if you can't commit to that meeting every time, every month, going as often as you can, paying attention to emails. I've done a couple of the RAMS guides for medical students. It's like you can be a writer, an editor, and those don't take, the writing takes a little bit of time, but if you pick a piece that's shorter, like a Pulse article or something, it doesn't take that much time. It forces you to kind of hone those skills that you'll need anyways. Like I did the DEI curriculum. I did a couple of those. Like, again, you can do these things on your own time, and they go to your CV, and they're national curriculum, things that you can do and get involved. So just pick a committee, join it. If you hate it, it's fine. You get to drop it the next year. You could even stop going to the meetings, but pick at least a committee and just kind of see what it's about, see what things you can get involved with. You will find and meet so many wonderful people that will help you in your career. To kind of piggyback on the PNT thing, to get promoted, you have to have letters from people that are outside your institution that you don't work with. And if you think about that, you have to meet other people, and so this is a great way to do that, because you can't ask for recommendation letters from your boss or your colleagues, and they have to be above your current level. So I'm an assistant professor, so to get to an associate, I have to find 3 or 4, I think it's 4, people outside my institution that know me, that are associates or higher, that are willing to write me a letter for promotion. And so committees can kind of help you start that process.
Right, and it's also like a great way to meet people sort of outside of your region, right? Yeah. And because that looks better. Yeah. And on these committees, because they're national, there'll be people from all over the place. There'll be people who are at sort of different levels than you are, and if you're junior, you're usually more senior. And it's a great way to network, which is awesome.
And get yourself invited to come and do grand rounds at their facilities.
Yes.
Yeah.
Yes.
So, and we just wanted to run real quickly kind of through the different opportunities at SAEM, because there's different things. There's interest groups, and these are kind of the least formal, or at least they have the least requirements from the SAEM Board of Directors. And you can actually join in anytime. And they do all kinds of projects. I mean, even though they're not formally committees, they don't have charges from the board, that kind of stuff. You can get involved with a lot of stuff. I met a resident who had gone to the telehealth interest group, and she was like, I had no idea that all this stuff was going on. And she's like, wow, now I'm working on these 2 projects. And so, she just went to one meeting, and she was like, I'm turned on to telehealth. So that's the interest group, and again, and there's good mentorship, leadership opportunities there. And then we also have the academies, and you can join these anytime, and these are also pretty big bodies. They do have some charges from the board as to what they need to get done, but it's a little bit lower than the committee. And again, you can do so much work. There's research going on through the academies. I mean, the Ultrasound Academy, I'm missing the Sono games today.
The Academy runs sim wars, like they do a lot of cool stuff that there's absolutely room for people who are junior to be involved in.
Yep. And they also, they support research, and you can network because you get on that academy, and you have access to all of those people, and you can post a message saying, hey, I'm starting this research project, and I would really like to talk to some other people who've done this, and you'll get a bunch of answers. So those are really cool. And then the committees are a little more formal. You can only apply once a year. They only take so many people, although most of the committees are pretty large. The board gives the committees their objectives, right? So it's worked out between the committees and the board. So you really, and the expectation is that if you sign on to an objective or to lead a subcommittee, that you really will get it done. So it's a little bit more formal of a commitment. But you'll also meet some of the power players in SAEM if you join the committees, because the committee chairs and the board, and you're going to get more tied in that way. So that's a more formal way. I started with interest groups, and then I joined a couple of academies, and actually that's given me a couple of national presentations there. And now I'm on a couple of different committees. But it does help with letters. It also helps with like institutional recognition. For our promotions, we can provide names, but they all have to be arm's length. So it's like people who know of our work, but who we have not worked directly with. And that becomes much easier if you have some contacts at other institutions. Anyway. So,
I mean, the committee by itself is scholarship, right? I mean, it definitely leads to scholarship. I have gotten a ton of didactics like this one, a ton of papers from work with committees, but the committee by itself is national scholarship, and shows that the fact that you were chosen to be on the committee shows that you have a national presence.
Yes, but you need to do something with that committee. So just being a member isn't good enough. So get yourself on an objective, so that you can say subcommittee member, blah, blah, produce, blah, blah, blah. So don't just be don't be a wallflower committee member. Pick one thing, and then do something with it. There's lots of stuff. And a lot of times, you introduce an idea and it gets carried forward, and then you wind up getting a whole lot of stuff out of that. So, but SAEM is just a fantastic place to go to boost your career and to get you promoted in your own institution. It's, I mean, we're all kind of testimony to that.
Yeah. So this slide has some kind of rough deadlines. Certainly, these are not meant to be like the end-all be-all deadlines for these things, just kind of a rough idea of when to look out for these emails and that sort of thing, how to get involved, how to sign up for committees, and how to get involved with projects.
And these are the specific things if you are looking for career development. So you'd say to your chair, I want to do the armed med ed thing. The application is due November 30th. And you have that information as you go to your chair with your negotiation. Hey, now I'm an APD. We need to have better education to improve our board scores. This is a program I want to go to. And these are nationally recognized as high-quality programs.
So I think we are close to the end of time. So I wanted to make sure, do we have any either anonymous questions or anyone else want to come up to the mic and ask any other questions?
You can also just shout them out.
Alrighty. All right. Well, thank you everyone for coming to our panel. We're happy to take any questions that you have. You know, if you think of something later that you want to submit one of the questions for, we'll keep an eye out on this, and we can kind of send out some more information, things like that.
Should be good to go.
Check, check.
Take your batteries. Okay.
Okay. All right, good afternoon, everyone. Thank you so much if you are coming to attend our session. Thank you for that. If you're not, no worries. We won't get offended. My name is Sadia Akhtar, and I'm the Associate Dean of GME at Mount Sinai Beth Israel, and also part of the Icahn School of Medicine at Mount Sinai. I'm here with my lovely colleagues, who they will introduce themselves.
Hi, I'm Guy Carmelli from UMass. I'm one of the education faculty there.
Awesome. Hey guys, I'm Serena Dacian. I'm APD at Duke University. I'm also the co-chair of our Justice, Equity, Diversity, and Inclusion, so JEDI committee as well. So excited to have you guys here to talk about representation matters, and we'll really talk about why this matters in our presentations as well as our material. And there's a little bit of an echo just for our team if you're able to work on that. So we have no financial disclosures. There's no conflicts of interest. I'm actually going to come to you, if that sounds okay, just because I don't like to be lonely up front by myself. So we'll kind of go into it, but we're going to basically just lay a foundation of what representation means. And then after that, we'll talk about some of the barriers to this or what not to do. And then we'll definitely share some resources on how we can do this well in our material as well. So why does representation matter? So representation is when our students or learners are able to see themselves in that material and really imagine themselves, in that place doing that job or that field. And what they've actually found is that actually the reverse is true. So when our students do not see themselves in that material or in the author group or as the teacher of that class, they actually can envision themselves in that role. And this really, you can imagine, causes them not to be able to meet those goals, and they actually do poorer in those classes itself. So this is why representation is really key to kind of keep our students motivated. Really, if we could tie this into their lived experiences and invite them into the conversation to share their own diversity and their own cultural competency and sensitivities, this can really make a big difference for this. And I do want to mention that while we'll be talking about just representation in materials, this really is talking about increasing the diversity of your classes, also increasing the diversity of your teacher and faculty group as well. That you need all three of those to make this possible. So having beautiful slides will not be enough to just increase the representation for your learners. So where do we see a lack of representation? I have 4 children at home, and I would say that we've gone through many, many children's books, like hundreds of children's books in the last decade of their lives. And there's a lot of literature out there, especially in the non-medical setting, about the lack of representation. They actually say for children's book, only 10% of those books contain either Black, Indigenous, or people of color as the main characters of those stories, so which is quite drastic. And actually, for some of those ethnic groups is actually less than 1%. And then if we bring this into the textbook, that also the same thing is true. About 60 to 80% of the images used are actually European white pictures versus if we talk about our BIPOC population, it could be less than 1%. And then also for some of those populations, it's not even existing in our textbooks itself. And so this is where, thank you, representation really matters, because we know that representation actually really helps to increase the cultural climate and the culture and actually student outcomes as well. So it's really important to think about how we're constructing our didactics and really inviting diversity into the conversation as we're teaching. And so a lot of times when we think about diversity, we think about gender or race or ethnicity for that. But I would actually like to challenge all of us that there's so much more to diversity than just those categories. And we know a lot about this from implicit bias kind of training and research as well. And if you think back to SAEM and our conversations that we had, I wonder how many of us have seen a person with a disability on a slide, right? I would say I have not. Actually, if I think back to the last couple of decades, I don't know if I have. And especially someone with, showing someone with a disability in a power of strength or showing their talent as well, right? So this is where we can really, show this diversity in a lot of different ways. Also, age is another thing. the extremes of age. A lot of times we see this stereotype. We know there's a lot of bias around age as we see them portrayed in clinical scenarios. Similarly, obesity, there's so much literature out there about physicians' perceptions of patients with obesity, how they get poorer care. And a lot of times, our slides don't represent actually all the strengths that this group also has. And also just sharing about the, clinical considerations that we need to think. Similarly, for our LGBTQIA plus group, a lot of times, we see this group represented in a way that may not be the most favorable. Maybe it's tied to stereotypes instead. And so it's really important to think about how can we actually optimize the representation of this group in a positive way, and also when we're talking about it in a clinical aspect, to take our bias and our own stereotypes out of it. And so this is really important because our students are noticing this. A lot of times when they see a clinical scenario that brings up the demographics, a lot of them wince because that might be the only time they see themselves represented in that material is when it's associated with poorer outcomes for a certain population. And a lot of those poorer outcomes are actually tied to social determinants of health, not actually that, population itself. And we'll talk a little bit more about that in the second half of our talk. So I would really challenge all of us to recognize that diversity really matters in our materials, and so we really need to be thoughtful. We can check our own biases by doing, for example, the IAT, the Harvard implicit bias test, to really check our own bias. And they have a lot of them, not just race and gender, but they have about weight. They have it on a whole lot of other aspects of bias that can infiltrate. And this really is hurting our learners, I'll say, because if they don't feel like they belong, they're not going to be invited into the conversation to actually engage in that material. And the loss of inclusion actually has been shown to have a higher attrition rate for these students, and also even a higher rate of depression and mental health illness and so on. So there's a lot of repercussions for students not feeling like they're belonging. So we can really do this with our material. I'll also say that our generations of learner, they're all about social justice. They're growing up in the world now saying that representation does matter, and they are noticing when we're not talking about our populations correctly or when we're perpetuating stereotypes. So we really need to be thoughtful because our learners will hold us accountable for this as well. So just we'll talk a little bit about when adding this to the conversation matters, how you can do that, and we'll give you a couple resources as well.
Well, thank you all for coming and listening to our talk. I can tell you really care about improving your diversity within your lecture materials. I'm tasked with giving some specific examples of what you should not be doing in the lecture to kind of improve what was just talked about under Sri's talk. So these are the 4 things we'll discuss. The first is the low-hanging fruit. If you want to improve diversity, you need to include that in your slides. And you want to also be careful about how you portray certain individuals. So let's say if you always show a doctor slide with a white male physician, or conversely, when you're talking about support or ancillary staff, you always include a female nurse. That could be going against improving equity and diversity within your slides. So it may be just out of convenience, because you can see I typed in Google what comes up on the first slide, but it could take just scrolling for a few pages, or Sadia is going to talk about some different websites that you can find more inclusive content. So maybe images like this where you have a minority physician and white male nurses could be better. Be careful about when you talk about certain concepts like teamwork, and we always use this image where we have all the hands in the middle and it's typically a white male hand on top. That could send a subliminal message. Rather, you can look for an image where there may be nobody on top and it's all kind of equitable. There are certain medical topics that Sri kind of mentioned that's prime for causing issues, such as in dermatology. There was a study that showed that 47% of dermatologists feel ill-prepared to diagnose certain conditions in non-white skin. And that's typically because there's a disproportionate number of clinical images that only represent white skin in textbooks. So you can see here I typed psoriasis in Google, and you can tell what kind of images came up. I did the same thing for urticaria and eczema and got the same results. The next point is to be careful not to include diversity in a biased manner. So Sri kind of mentioned this, and I'm giving a specific example. If the only time you include someone who's like Hispanic or an older female is to discuss a case of someone who is uninsured and has poor health literacy, then that kind of sends a message about how you view this type of demographic. Again, if you want to talk about homelessness and psychiatry, and this is the only image that you include of a black individual, that is also biased, because homelessness and psychiatric illness spans all races, genders, ages, and so we should be careful about how we include images. Sri also mentioned sexual orientation, and there's been a lot of stigma towards this and sexually transmitted diseases, and I don't think that anymore we need to link this to discussions of HIV. I mean, we could just discuss the illness as it stands without needing to mention sexual orientation. You can bias people without even discussing the individual. Oftentimes during presentation, we discuss, oh, the patient came from an outside hospital or rural area or community site, and we suggest that they got inferior care in that location because of where they come from. And so I think it's kind of unnecessary. I know I trained in Brooklyn, and you'd always hear, the Manhattan hospitals are superior, and I think that's a little unnecessary, especially in our lecture presentations. We don't have to mention that. The next point kind of goes off of what I just talked about. Sometimes we don't even need to mention someone's demographic. It might be unnecessary for the point we're trying to make. I remember in 2010 when I was a medical student on the surgery rounds, the old school attending physician pounded in my head that every presentation must include gender, age, demographics, race, sexual orientation, because that's the only way we can risk stratify them and be able to treat them. But I think this is kind of like an old school mentality that leads to bias in medicine. There's a lot of literature that shows that we do have implicit bias, and it does affect our medical care, so much so that it's even made it into the social understanding that this is occurring. And so how we can work on that is to try to remove unnecessary demographics from our presentations and our lectures if it's not a requirement. So for instance, in this case, do we need to mention that the lady is African in order to have a clinical conversation about sickle cell, or can we just focus on the sickle cell disease? We should be careful about attributing certain adjectives to a certain individual. So on Wednesday, I helped moderate a panel where we were discussing giving feedback to certain types of residents. And during the cases, I decided to remove information such as gender. So we had a case where it was like the cocky resident and the timid resident. And so instead of saying a cocky male or a timid female, just propagating stereotypes that aren't true, I just made it a specific resident without talking about stuff like gender. And then finally, we should be cognizant of the different learning styles that exist amongst our learners and be as inclusive as possible toward them. So some learners prefer to learn via auditory channels, some are more visual learners, and I feel like the pendulum has swung in our lectures where we're all pictures and maybe no text at all, and that might be making more trouble for those who learn by reading. There are also tactile learners who learn more by doing, and maybe we should alter up so that it's not all lectures, but some workshops or simulation just to be more inclusive. Be careful about the colors that you have in your presentations, because some people are not able to see all the colors and might not be able to understand the graphs and tables that you put up. And then finally, we should be careful with symbols and language, which could complicate things during our lecture. So while symbols like this might be easy to understand for some of us, others may have a little bit harder of a time to understand and interpret what you're saying. And during our lectures, we really want to reduce the extraneous load to make things as easy to understand as possible. Similarly, in medicine, we value having fancy, complex words to, designate certain conditions. And while that's fine during an oral presentation or on documentation, I think during a lecture, it's just easier to make it more easily digestible for our learner. And I'm going to pass it off to Sadia.
So thanks, Guy and Shree, for setting the stage. I just wanted to share some information with all of you about what actually can be done if you want to do this correctly. And again, just to reiterate, we have no incentive financial disclosures or anything of that nature. We don't prefer one website over the other. We just wanted to share the information with you. So obviously, we are teaching in an environment that is, in addition to the didactics, we have small group discussions, we have simulation, we have a lot of different other ways that we are educating our learners. And I just wanted to walk through a couple of different venues and also share with you some websites that you can use. So in a small group discussion, I think it's really important to understand that as an educator, you need to know who the learners are that are going to be in that small group and also the faculty that are going to be involved. In addition, when you are usually doing small group discussions, it may be case-based, and so going back to what Guy was talking about, having a diversified sort of representation of the cases that are being discussed in that small group discussion is really important. In addition, looking at the workshops, that you definitely have to understand that I think as a person who is of color, it's really interesting to see what other faculty are around and who also participates in the workshops that we sort of set up for our learners. And if you put some thought into it and do some advanced planning, you can actually make sure that it is a diversified faculty that is being represented in these workshops in addition to the learners and the cases that we were talking about. In regards to simulation, I think simulation has come a long way. Obviously, there are a lot of clinical scenarios that happen, but you can also teach a lot of soft skills in simulation, for example, like professionalism, conflict resolution, etc. All of those being, again, in a very diversified fashion. What's important to understand is in the simulation setting where it's clinical stuff that's going on, we can actually use mannequins that represent different skin tones, different ages, and body habitus, and I think that we don't really sometimes think about all the ways that you could have diversity in the simulation setting. So just to give you an example, this is one of the websites that specifically is catering to the needs of including different skin tones when you are working with a simulation kind of setting. Now sort of moving on to websites, I do want to share with you, so the current presentation that we're using, the actual format that we're using is from a website known as Presenter Media. And again, I have nothing as far as like financial incentive to say this, but personally, I thought that this would be a good thing for us to use for this particular talk because Presenter Media, it's a paid subscription, but it has a lot of different formats where on topics and different type of areas of interest, you can actually get like a template for your PowerPoint and utilize that. So for Presenter Media, for diversity, this is actually the template that came up, and I just wanted to share with you. These are some of the pictures and some of the formatting that you can include in your presentation. So things that are already set for you to utilize. And again, these are images of different type of diversity representation that can be included into your PowerPoint. So now sort of to move to websites, I also wanted to just share, I think it's hard to sort of sit there and figure out, okay, well, how do I include images in my lecture, for example, that represents diversity, equity, and inclusion? One of the biggest places I think that all of us go to is Dr. Google. So if you go to Google, you click images, and then you click Creative Commons, you will be able to get some free imaging. The other issue, though, is it has to be free because who wants to pay extra dollars? There are actually some great free websites that you can include diversity type of images, and I'm just going to go through a couple of those slides and then transition to the slides which actually represent paid subscriptions for images that represent diversity. So the next one is unsplash.com. This is actually a really great website. It has a lot of different imaging that represents like diversity, equity, inclusion type of images. And again, it's free. You just log on and you can select and do a search. The other website is Wikimedia Commons, and again, this is really for any kind of topic. Again, free images that can be obtained. Moving on to Picnoy, this is definitely, I think, another great resource where you just go on to picnoy.com and put in your search topic that you're looking for, and then you'll be able to get free imaging that you can include. The other one is PickWizard. Again, same system. You log on, you put in your search engine type of topic that you're looking for. You can say, you know, diversity, equity, inclusion, whatever topic you want to include, and you'll be able to get some images from there. The next one is Pixabay. Again, these are all free. You put in the search word that you're looking for, and then you'll be able to identify those images. Nappy.com is another one, or nappy.co, I should say, is another one. And this is a great website specifically for diversity and having images of people of color. And again, this one is free. So now sort of transitioning to the ones that are paid subscription, you know, obviously I think they'll have a lot more imaging there, but again, you do need to pay for it. So this is the website Stocksy. And again, I am not showing any images from that website because of the paid situation, but the other website is Diversity Images or diversityphotos.com, and you can again specifically get images that can be paid for to be included into your learning material. Another one is Create Her Stock, which I think is really important. Again, female, person of color, they have images there that can be included of a variety of different activities specifically towards the female of color. And then we have Black Illustrations. Again, it's a paid subscription. You pay for the images that you're looking for. There's also Shutterstock that I think we're all very familiar with. Again, lots of images there, but you do need to pay for those to be included into your lecture material. And then there is POCstock, which is peopleofcolorstock.com, which again, a lot of diversity type of imaging that can be included, but you do need to pay for that imaging. And then there's Megapixel. Megapixel is great for imagery and a lot of different type of scenarios that can be included. Again, this is a paid subscription that you would need to download for the images. You'll have to pay for that. And so in conclusion, we just wanted to, you know, keep on track with time and of course open it up for any questions, but we really do feel that it's important, and hopefully today we've sort of explained how it is important to include diversity, equity, and inclusion into your learning material, and to really appraise the information that you already have. Maybe the next time that you're preparing a lecture, a small group discussion, or a workshop or a simulation session, you can sort of reflect back on what you've learned today. And then hopefully with the websites that we've shared with you today, you can actually use some of those images to diversify your learning material. And so with that, we just wanted to share our email addresses. If anyone has any questions later on, please feel free to get in touch with us. And if there are any questions, we're happy to answer them. Thank you very much, everybody.
Into the mics, yes, you got it. It's like conference. We could make your residents come up. Are these all? What's that? Are these your people?
Yeah,
Yes, mostly.
my residents, yeah.
Oh, well done. Did you pay them to be here? No. I don't know.
No, they were dropping off. They were just dropping off their luggage. And it happens to be right by this ballroom.
Oh, perfect.
Yeah. Do you guys want to get up and go to the computer, or?
Yeah. I thought there was a clicker. The last group was using.
There was a clicker.
Is this it?
There's usually that looks like a.
That looks like a clicker. Yeah, because that's a green button.
You're gonna have to do the video though. Yeah, I'll get up to do the video.
Maybe. Or. And then one of you sit here. All right. Should we,
Oh yeah, let's get started.
We're on?
Because he's got to go.
So I'll have him up here.
Who's talking? Should stand up there. You think so?
I am amazed at how many bodies are in these seats. Thank you for being here. This is very exciting. Congratulations to you. 12:30 on Friday. This is fantastic. I am Jeff Siegelman from Emory, and together with Drs. Bertoli and Miras, we're going to chat over the next 19 and some minutes around how best to incorporate interpreters into your clinical care. I have unrelated research support from Enchroma, which is a company that's maybe more relevant to the prior conversation around color blindness. But today we're focusing on really the impact of language barriers on care for linguistic minority populations, and how best to utilize medical interpreters in the clinical space. And so we'll take this next 20 minutes to go through some background and some cases and best practices with you. Before we dive in, maybe to set the stage a little bit, I'd love to get your thoughts on some struggles that you all have had with caring for patients who cannot converse in spoken English. And so if you wouldn't mind jumping on the poll everywhere there, we can take just a moment to share some brief thoughts, and I'll read them out for you. Just go ahead and type away. So one person speaks some increased difficulty building rapport, and then it takes time. It takes using an interpreter, or and that's certainly for sure. This is really a weird way to say this. So people speaking to time, difficulty communicating. that they're under triaged, which is certainly something that we deal with. So as over the next 15 minutes, we'll try and take some of these thoughts into as we approach some best practices for taking care of these patients.
I just want to add, I appreciate the honesty in some of these responses. They are anonymous, which always helps, but I think that all of us feel that that burden of not enough time with the patients that we have, and now we have to take an extra step and involve 1 or 2 or 3 other people to try to add that on. And I think that it's okay that it feels like a burden, because I think that helps you recognize that you may already have a bias going into that encounter, and then it helps you prepare a little bit better for that encounter.
Hi, I'm Dr. Mars. So a little bit like, why are interpreters important? And it's really comes back to effective communication, right? And effective communication not only helps you identify what the patient is there for, helps you achieve the diagnosis, but even from a medical legal sense, communication is key. So you're not only protecting your patient, but you're protecting your own practice as well. There's been numerous studies that show that when you have interpreters involved in care, that patients report feeling like they can build a rapport, feel like their satisfaction levels are high. And that's imperative, right? And I think it's so, you know, that word cloud is interesting. The biggest word that was put up is difficult. And I, as a former interpreter myself, I would agree. It was an adjustment for my own practice to have to go from seeing English speakers to where I work now at Parkland, where about 40 to 50% of my patients are Spanish speaking. And that was a difficult adjustment for me. And so I think difficult is a very appropriate word, but if you take a look from the patient's point of view, that interpreter is the only way they can access the world around them. And that's why the interpreters are important. There's also customs, nuances, cultural aspects that unless you're part of that culture, you're not going to understand or fully appreciate. And interpreters can help bridge that as well. So who can be an interpreter? There is not a standardized interpreting catch-all for everyone, and different languages have different certifications, and even in states are pretty different. But let's talk a little bit about ad hoc interpreting, and this is kind of interpreting on the fly. We do a lot of things on the fly in the emergency department, and a lot of the times we may not have an interpreter readily available. The VRI, video relay interpreting, or the iPad, the Wi-Fi is not connecting, or there's not an interpreter showing up because the language you need is so difficult to attain an interpreter at 3 in the morning, and you have a family member there, and you're going to use a family member over not using anyone, right? But there are, there's significant considerations that need to be thought about. For example, when you're using a family member to interpret, you're really taking away the patient's ability to speak for themselves, because the family member may be dismissive of the patient's complaints because maybe the patient has complained about this all the time. The family member doesn't think this is a big deal, and that's going to come through when the family member's interpreting. Or you could have the complete opposite happen, where the family member may be exaggerating or adding on symptoms that the patient's not really feeling. You're not getting a true interpretation of what the patient is saying. You're getting a filtered message going through the family member, and that's when you start mixing advocacy, patient advocacy, and interpretation. And those are two very distinct things. And so it is very difficult for someone to be a patient advocate while being objective to interpret. It's very difficult to do. And sometimes it's necessary, but as long as you're thoughtful and mindful of this, it can be done. But types of interpretation, there's in-person, where the interpreter is actually at the bedside. There's video interpretation, so that's called VRI, so video relay interpretation, and a lot of us use iPads for that. And then there's telephonic, which is a telephone landline type of interpretation where someone's on the phone. All of these types of interpretations do qualify to meet a standard of if you're needing an ASL interpreter to meet the ADA law or Americans with Disabilities Act that require that interpreters be present at medical facilities or medical encounters. All of these do meet that standard. However, There are significant nuances about video interpreting and telephonic interpreting, which we'll kind of go through a little bit later. When at all possible, getting an in-person interpreter is by far the best choice. It is the gold standard, and we'll touch on that in just a second.
So I'm Jason Rotoli. I'm from University of Rochester. I'd like to give you guys an example of a patient interaction. I'm going to play a video here in a second. And in the interaction, I'd love for you guys to focus on whether I am using medical language or not, the speed and the cadence with which I talk with the help of an interpreter, my engagement of the patient, and also my positioning. And I might ask you if I did well or not well afterwards.
Okay, so I have all of his test results. Can you just tell him that his CAT scan and his labs were all normal? And I think he just has a little bit of inflammation.
Thank you for letting me know.
Oh. Inside of his abdomen, and he probably can just take Tylenol or Motrin Q6 hours.
He's saying that he'd like you to just direct your talking to him instead of to the interpreter.
Oh, okay.
So I'm curious, from anybody in the audience, maybe who has not seen this video before, I know a couple of you may have, what were your thoughts on my interaction with the patient? Feel free to raise your hand. We'll bring the mic right over to you.
Yeah, so you did a good job. It was directing it all towards the interpreter, so you could tell that there was something off. Like you instead of talking directly to the patient, you were just talking to the interpreter. And then there was a couple times, instead of waiting for the interpretation to occur and to kind of hear what the patient's saying back to you, you just kind of kind of railroaded over them or spoke over them, trying to get whatever your agenda was, which is something that I think we all have probably been in that place before. We're like just trying to get in and out of the room, just trying to update the patient real quick about something. So those are kind of two things I noticed.
Very good. Thank you very much. Those are 100% correct. Luckily, these are my friends and colleagues in this video, and some of this actually was organic. I didn't even mean to cut her off while she was interpreting, but I did accidentally, so I left it in there. But you're exactly right. I did not adjust my speed. I didn't wait for the interpreter to finish saying what the patient was saying. I didn't even actually notice the patient was trying to communicate with me because I was directing all of my attention and my language to the interpreter. And I do think that there is a time to engage the interpreter. They are a member of the team, but most of your speech and most of your attention really should be to the patient. The caveat to that is if you're trying to assess for language fluency or dysarthria or encephalopathy, then you can pull the interpreter aside and ask them kind of what their thoughts are about that. But otherwise, all your attention should be toward the patient, absolutely. And again, really trying to engage that person. And the last thing I'll touch on briefly is just positioning, which is a good segue into our next slide, which is really the bulk of our talk. But positioning with the interpreter and the patient is going to be incredibly important. In our ED, where I am right now, the space is so unbelievably limited that it's really hard to make sure that everyone has visual and audio access to the interpreter and to the patient. But trying to set up the best access possible is going to be your gold standard. And I would just ask the patient and the interpreter, what is the best way that we can communicate clearly? Because they are going to be the experts in that situation, and they will let you know. The next thing when working with an interpreter and a patient is to really address your patient in the first person. So I did not do that at all during the video, but asking the person, and how do you feel today, and what can I do for you, as opposed to can you ask him, what's going on. Same thing when you're delivering information back to the patient, their test results or whatever, your CT scan shows. Pausing, I touched on a little bit, but really trying to adjust the speed and the cadence of your speech and what you're delivering. This becomes particularly important in the deaf community, where there is not necessarily a word-for-word translation for everything. So there may be a sign for heart attack, but there is a lot of explanation and visual imagery that has to happen with the interpreter so that they can really make sure the patient is understanding what that term means. So allowing the interpreter to catch up before you move on is going to be really important. And also allowing the patient to interrupt and ask a question or make a comment is necessary. I think assessing for understanding is something that we can do with all of our patients. It is not only the patients who do not use the same language as you or I do in the encounter, but really phrasing it with, what can I explain better to you? You know, what questions do you have? As opposed to, do you understand everything, or do you have any questions? I think if you take the burden off of them and say, what can I do better? It allows the patient to feel a little bit more comfortable in trying to ask those questions. Sort of setting expectations and prepping for the encounter is going to be really helpful. It will help with planning for things like speed and cadence. It will help with planning for adequate positioning. Sometimes you're going to go into a situation where it's really sensitive information that's going to need to be discussed, and that can help the interpreter kind of set the stage and just be ready for that conversation. Some special considerations, Dr. Myers talked about using family as an ad hoc interpreter. I think in the ED we have to do what we have to do, so if you have nobody else, of course you're going to use a family member. But in addition to maybe minimizing or maximizing a certain complaint or a problem that the patient may have, I think there is also the concern for medical language fluency. Obviously the patient and their family member have an established language and they're more than fluent, but you'll often be faced with a 16-year-old interpreting for a parent, and you really need to make sure that that person knows how to translate or interpret the medical words that you're saying. And most of the time they don't. And I struggle with that sometimes because you want to engage the family and you want to make sure that they're involved, but at the same time I need to make sure what I'm saying is coming across appropriately and that what you're saying is also coming across appropriately. So keep that in mind. VRI I'll leave for Dr. Myers to chat about, but it is a backup. At best, I would say. It is fraught with complications, whether you're using a hearing or a visual language, and you can think about Wi-Fi access and the battery dying, and think about your patient who maybe is bent over vomiting and trying to get that screen down in front of their face, and then think about space in the ED. Like, it's just impossible. There are a couple of pitfalls that we'd like you guys to try to remember and avoid. The first thing is using English idioms. So, I'll give an example. To beat a dead horse. We all know what that means, but to translate that into American Sign Language, you wouldn't really say like beat a dead horse. Like that is, it wouldn't mean anything. And so speaking plainly and directly is a much better way to get your point across. Avoiding complex sentences or asking multiple questions at the same time, which I think we all do, right? Are you having any nausea, vomiting, diarrhea, or anything like that? Well, that's like 4 questions that now you just ask the interpreter to interpret for the patient. Certainly making assumptions is applicable to any of our patients. Really try to get a sense of their educational level, their health literacy level, and try to match that. And the last thing, which I really hope is not happening, but trying not to infantilize your patient. Use an adult voice. If you're speaking to an adult, use adult terminology while avoiding, complex medical terminology. And the last thing I'll talk about is, how do you get good at this? How do you become proficient? And the short answer is that you really just have to do it, but you can practice it, and that's what I would really try to emphasize. In our residency, we had simulation. We would train some standardized patients to come in and have the residents do an H&P on them, and then the standardized patients are usually from the target community that we're working with, so from the Hispanic community or the deaf community, and then they're the ones to provide the feedback. So it was a great simulation exercise. You can use case-based role-playing with, amongst yourselves, and then really trying to engage in a conversation with your interpreter services, who again are going to be the experts in this, to set up some time to do some education for you and your colleagues.
One of the things that that Dr. Rattoli here is mentioning is prepping the interpreter, and I can tell you as an interpreter how helpful that is. So before you walk into the room saying, "Hey, we're going to go see a patient, belly pain," female 40s, male 20s, whatever, giving that context, or like, hey, I'm about to break some bad news, just a heads up. Giving that context is so valuable for the interpreter because they can already start prepping specific terminology, words, adjectives that they're going to use. They're going to change their demeanor, their mood to meet the nature of the conversation that's about to be had. If they don't know what they're walking into, that's when a lot of problems they're already doing things on the fly, right? Interpreters are phenomenal multitaskers. So information is literally coming in one ear. They're switching it into a different subject or a different language, and it's coming out in a completely different language simultaneously, right? So minimizing the cognitive burden by prepping them is so helpful. We'll talk a little bit about ASL interpreters since that's much more of my background. Using the whole terminology with deaf and having a deaf identity. The deaf community, deaf culture is really founded on the language of ASL. And so we don't want to assume that just because someone is not able to hear that maybe they know ASL or maybe they don't. So again, you want to find out what their language preferences are. Maybe they're fluent in English as their primary language. They just need some other kind of accommodations and not necessarily an ASL interpreter. Education level is huge, and again, this goes back to why you don't want to use family members, because if you have a 16-year-old interpreting, then you have a 16-year-old educational level message, that you're giving that 16-year-old being interpreted, giving to whatever their parents' educational level is too, whereas an interpreter can match the dichotomy between a physician and the patient themselves. And so it's just another pitfall to take out of the equation by not using family interpreters. So that way you can match the educational level. And I mean, that's the same as like in discharge paperwork, right? We don't type, you have cholecystitis, you don't throw all these medical terminologies in. We try to match what the patient can understand. Positioning, so this diagram is actually, I think, a great way, and this applies to spoken interpretation as well. You want to have the interpreter by your side, so the patient can see you and the interpreter at the same time. If you split with the interpreter, and the patient's just laying in the bed, and they're going to be talking to you, but making eye contact with the interpreter, and they can't see how you're reacting, they're not getting any visual cues from you. So this applies to ASL interpretation, to spoken interpretation. Have the interpreter at your side, or go to the side of the interpreter, so that the patient can communicate with you and the interpreter as one team, almost as one individual, and that facilitates communication well. And then that falls into eye contact and body language, right? Significant amounts of messaging, communication, language is done through nonverbal cues. And again, if positioning isn't established well, so the interpreter is on the other side of the room, the patient doesn't have the benefit of catching all these nonverbal cues as well. And then cultural impact on information sharing. This is kind of specific to the deaf community in the sense that when news is being delivered or stories being delivered, it's usually the main point is the very first comment, right? So if you're going to break something like you have a mass, maybe in a hearing patient, you may say, you may kind of work up like, hey, all your blood work looks good. How are you feeling right now? Do you feel nauseous? Does medication help? Okay, I'd like to talk to you about your chest x-ray findings. If you did that in ASL, the patient would get so lost in terms of like, okay, what is the point of this conversation? So that's when the interpreter can kind of play into the cultural impact of communication, listen, take in this message and be like, you have a tumor on your chest x-ray, everything else looked okay, and then that facilitates your intent and your messaging through a cultural barrier, right? And the case or in-person interpreter. So this is a kind of like a hot topic in the field of interpreting. This goes for spoken language, ASL. VRI, from a business standpoint, it makes sense, right? In-person interpreters are expensive. VRI is cheap, it's convenient, and you can have interpreters on demand like that. So there are huge benefits to it. However, it is the most difficult form of interpreting there is. I can tell you as someone who used to interpret behind the iPad, it is so hard. So much in fact that you have to have years of experience typically to even interpret in VRI in the community setting before you even go into VRI. But the issue is you have zero context about what you're about to interpret. So you're thrown into a room, who knows if you can even see, you may be facing a wall, but all you hear are people talking. And you get messages like, well, does it hurt still? What is it? What is it? Does hurt? Who's talking to who? Is that a patient talking to another patient, or a family member? Is that the doctor? Is that the nurse? Like, you have no context whatsoever, and that forces the interpreter to be very, very, very direct in what they interpret. So they will interpret things very literally because they have no context and can't do it otherwise. And so things like idioms will be interpreted very literally. So they will interpret, if you say, oh, we don't need to beat a dead horse, we've covered that already. They will literally interpret that because they don't have the context to fall back on to appropriately interpret the message. Again, it's convenient. We got to do what we got to do in the emergency department, and I get it. But I've spoken to the National Association for the Deaf has a huge stance on this, and they really advocate for in-person interpreting, especially with ASL. It is a 3D visual language, and so you're putting it on a 2D screen, which really minimizes the ability to communicate. But I've spoken to my Spanish-speaking and interpreting colleagues, and they are just as passionate about this as I am. They realize that being in the room, there's such a more of a connection and communication with the patient, with the provider. Cues can be taken on, right? If the patient starts getting worked up and angry, the interpreter can match the affect and the mood of the provider to try to calm the patient down, right? A video relay interpreter cannot do any of that. So there's so many benefits to in-person interpreting. And so really trying to study the value of in-person interpreting, I think, will kind of offset the cost of interpreters, right? I think there's so much benefit to be had that it is a good investment, and we do need in-person interpreting. Yeah, so that's pretty much it, guys. We're happy to answer any questions, but again, thank you for coming. I hope you guys had a great week at SAEM. Thanks for coming on a Friday afternoon.
Appreciate your time.
I'm sure many times I've fallen into those traps and made snafus in terms of idioms or, poor eye contact or other things like that. I'm sure I've made those mistakes, but I can definitely say in my career that I've never received any feedback from an interpreter on things I could have done better or mistakes that I made. And so I'm curious if in your experience, did you feel empowered to give that feedback? And also, what are the things I could do better to elicit that feedback to improve my practice?
When I worked as an interpreter, I did a lot of healthcare because I was in pre-med and in med school, and that's what I wanted to do. I think there's a power dynamic. I'm not going to tell the doctor how they need to interact with the patient because I'm just the interpreter. I'm just there to facilitate communication. But I would strongly recommend maybe after a patient encounter as a physician or provider to just touch base with the interpreter and be like, how did that go? I do that a lot in terms of patients with encephalitis, right? Or they're altered. I'll after the encounter, I'll go to the interpreter how do they seem to you? Are they a little bit off? Or I'll talk about with interpreters after a patient encounter if there's been some kind of family dispute. So this happens a lot, right? You have a patient and a family member, and they're just having a 20-minute conversation and arguing about something, and you're just kind of standing in the corner. You have no idea what's going on. That's when I'll pull the interpreter and be like, okay, what's the synopsis of this argument so I can catch up, right? But I think the other thing is I catch interpreters a lot of times using third-person language, right? So standardizing interpreters, I think, is important to make sure they know what they're doing as well. But I think asking interpreters, hey, how do you think we could have done this differently? Especially if the patient seems frustrated with communication, right? Because if the patient's frustrated with communication, nothing else really, the whole patient encounter is going to be a moot point, and they're not going to be happy with the care that they received. So.
I'll just add, Dr. Myers had mentioned the cognitive burden or load that the interpreters are bearing during that encounter. They are doing things simultaneously. They're acting as an advocate. They're acting as a cultural and a language mediator. And so it might actually be challenging in that setting to ask for feedback. If you have an interpreting department, it would probably make more sense to try and get some formal education, but I know resources vary. But trying to do it outside of the clinical environment might even be better for them. It might also help to remove that power dynamic. One more.
I was wondering, oh gosh, my voice. In terms of the equitable care being delivered, is there any work or research kind of looking at differences with VRI and in-person interpretation? And also, like, is there any work or investigation kind of like looking at that in terms of how much experience a certain interpreter has and how that might impact care for a patient? Do you guys know of anything like that?
I don't know if there are head-to-head studies looking at outcomes. There are definitely qualitative studies with patients demonstrating the same theme, certainly in the deaf community, that in person is just better. And that's where we got a lot of our pitfalls from, is that data itself.
Yeah, there's tons of qualitative research saying that patients prefer it. They significantly prefer it. In terms of outcomes, it would be interesting to see, you know, how, like, doing kind of like a trust scale, or how did the patient feel like they establish rapport, and seeing if there's any differences between an in-person or VRI interpreter, right? Because again, from the patient's point of view, that interpreter is their window to the rest of to anyone in that room, in the hospital, right? And if that person's in an iPad, they're probably not going to feel as well advocated for, right? And that's what the qualitative research has shown.
To answer your question about the experience part, I think that is one of the real big plugs for in-person interpreters. Typically, if you are working with an agency that knows that this is a hospital facility, you have a relationship with them, they're going to send somebody who has medical experience. Certainly in our institution, we have 40 or 50 staff interpreters, so we know that they have the qualifications to be there. When on the other hand, if you're using a phone interpreter or a VRI person, you really have no idea what their qualifications are. You've never worked with them before. You know, I had this happen to me the other day where the Spanish interpreter didn't know the word for wheezing. And fortunately, my resident did and was able to convey that, but I was like, wow, this person is probably not qualified to be in this situation.
All right, I think
Well, thank you, appreciate it. Great job. Thanks, man. That's it.